सीएनटी क्लिनिक को। क्लिनिक थोड़ा छोटा शब्द है, अभी इसको बदलना पड़ेगा। वैसे आप लोगों को मालूम होगा ना कि एक्सकेवेशन शुरू हो चुका है नए हॉस्पिटल का।
आज वर्ल्ड वॉइस डे है, विश्व आवाज दिवस। इस अवसर पर हमारे डॉक्टर एस के दुबे जी भी मेरे साथ हैं। उन्होंने भी पेड़ लगाए, कई डॉक्टर्स ने पेड़ लगाए। हम सब जानते हैं कि आवाज का महत्व क्या है। विश्व आवाज दिवस की इस वर्ष की थीम है, स्लोगन है, योर वॉइस मैटर्स। आपकी आवाज मायने रखती है। ये हमारी वो बेटी है जो पहले बोल और सुन नहीं सकती थी, अब इसका इलाज हो गया है। और ऐसा और कोई बेटा बेटी हो तो छोड़ना मत, मामा को खबर करना, उसका पूरा इलाज करवाया जाएगा। अब ये बेटी बोलने लगी है और माँ है इनकी। अब बेटी कुछ बोले।
एक बार तालियां हो जाए। बच्ची ने बोला माँ माँ। पहले ये बोल भी नहीं पाती थी, सुन भी नहीं पाती थी, इसलिए बोल भी नहीं सकती थी।
दिव्यशील फाउंडेशन के द्वारा आयोजित किए गए इस कार्यक्रम में आप सभी का हार्दिक स्वागत है। जैसा कि इस वीडियो के माध्यम से आपने देखा, हमारे आज के इस कार्यक्रम के मुख्य अतिथि हमारे मामा शिवराज सिंह चौहान, हमारे विशिष्ट अतिथि विश्वास सारंग सर पिछले कई वर्षों से कान नाक गला रोग विशेषज्ञों के साथ किसी न किसी भूमिका में जुड़े हुए हैं। मैं उनसे निवेदन करूंगा कृपया करतल ध्वनि के बीच में मंच पर अपना स्थान ग्रहण करें। मैं निवेदन करूंगा इस कार्यक्रम के आयोजक डॉक्टर एसपी दुबे और डॉक्टर संजय अग्रवाल से कि वे मंच पर अपना स्थान ग्रहण करें। पास्ट एओआई प्रेसिडेंट डॉक्टर दीपक हल्दीपुर से मैं निवेदन करूंगा मंच पर अपना स्थान ग्रहण करें। बैक टू बेसिक प्रोग्राम की ऑपरेटिंग फैकल्टी डॉक्टर सतीश जैन सर से मैं निवेदन करूंगा कृपया मंच पर अपना स्थान ग्रहण करें। सर के लिए जोरदार तालियां। हमारे आज के इस कार्यक्रम के मुख्य अतिथि मामा और विशिष्ट अतिथि विश्वास सर पर्यावरण के प्रति बहुत सजग है। कहते हैं मैंने एक चिड़िया पाली, वो उड़कर चली गई। मैंने एक गिलहरी पाली, वो भाग गई। मैंने एक वृक्ष लगाया, चिड़िया भी वापस आ गई, गिलहरी भी वापस आ गई। इसी विचारधारा पर अमल करते हुए हम आज के हमारे अतिथियों का स्वागत फूलों की बजाय पौधे से करेंगे। मैं निवेदन करूंगा आज के इस कार्यक्रम के दोनों आयोजक डॉक्टर एसपी दुबे और डॉक्टर संजय अग्रवाल से कि वे पौधे से हमारे मुख्य अतिथि मामा शिवराज सिंह चौहान का स्वागत करें। सर के लिए जोरदार तालियां। मैं दोनों आयोजकों से पुनः निवेदन करूंगा कि वे हमारे विशिष्ट अतिथि विश्वास सारंग सर के पौधे से स्वागत करें। सर के लिए जोरदार तालियां। मध्य प्रदेश एओआई की प्रेसिडेंट डॉक्टर यामिनी से मैं निवेदन करूंगा कि वे पौधे से डॉक्टर दीपक हल्दीपुर का स्वागत करें। सर के लिए जोरदार तालियां। यामिनी मैडम। हाँ। मैं निवेदन करूंगा डॉक्टर सुधाकर वैद्य से कि वे पौधे से डॉक्टर दीपक हल्दीपुर का स्वागत करें। सर के लिए जोरदार तालियां। किसी भी शिक्षण संस्थान का प्रथम दिवस मां सरस्वती के चरणों में अर्पित होता है। आए हम सब उस मां सरस्वती का वंदन करें, जिनके आशीर्वाद से हम सुशिक्षित एवं सुसंस्कृत बनेंगे। वंदना में दीप प्रज्वलन उस अपार सत्य का वाहन है, जिसके स्पर्श मात्र से हर चीज पवित्र हो जाती है। मैं मंचासीन अतिथियों से निवेदन करूंगा, कृपया दीप प्रज्वलन कर इस कार्यक्रम की शुरुआत करें।
आरोग्यं धनसम्पदा शत्रुबुद्धि विनाशाय दीपं ज्योतिर्नमोस्तुते दीपं ज्योतिर्नमोस्तुते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदा।
इसी के साथ मैं निवेदन करूंगा आज के इस कार्यक्रम के आयोजक डॉक्टर SP दुबे से कि वे मंच पर अपने स्वागत भाषण से इस कार्यक्रम की शुरुआत करें। सर के लिए जोरदार तालियां।
आपने वीडियो देखा, वो वीडियो जो शुरुआत में माननीय शिवराज जी बोल रहे थे वो 2014 का था, जब पहला बैक टू बेसिक प्रोग्राम शुरू हुआ था। बैक टू बेसिक प्रोग्राम हमेशा से देश के जाने माने विशेषज्ञों को, जैसे कि आज सतीश जैन साहब हैं हमारे बीच में, हमारे दीपक हल्दीपुर साहब हैं, हमारे राजीव पचौरी जी हैं, हमारे मिनेश जुवेकर जी हैं, हमारे और दूसरे मिलिंद नवलखे जी और सुधीर कदम जी कल अपना कार्य करके सुबह चले गए। ये सब लोगों को बुलाकर बेसिकली हम उनसे सीखते हैं और सीख के अपने अपने स्किल को एनहांस करते हैं, और एनहांस करने के बाद उस स्किल से हम अपनी आजीविका तो अर्जित करते ही करते हैं, लेकिन मरीज को सही इलाज देते हैं। आज ये 19वां बैक टू बेसिक प्रोग्राम है, साल में 2 करते हैं, लेकिन कोविड के अंदर कुछ अनियमितता होने से 12 साल पूरे हो गए हैं अस्पताल को, लेकिन ये 19वां बैक टू बेसिक प्रोग्राम है। ये मेरा सौभाग्य है और ये सभी ENT सर्जन्स को मैं बताते हुए मुझे गर्व होता है कि माननीय शिवराज जी और विश्वास सारंग जी, जैसे कि आपने देखा कि 2014 के प्रोग्राम में जब साहब मुख्यमंत्री थे और उस समय विश्वास सारंग जी विधायक थे, वहां पर उपस्थित थे। 5वें साल के अंदर जो है, जब हम लोगों ने एक मेरी आवाज सुनो प्रोग्राम किया था, तो उस समय क्या हुआ था कि बहुत ही इंपॉर्टेंट मीटिंग के कारण शिवराज जी को दिल्ली में रुकना पड़ा था, लेकिन विश्वास सारंग जी ने उस समय जाके उसका उद्घाटन किया था और रात को आके शिवराज जी ने उस कार्यक्रम के अंदर सम्मिलित हुए थे। फिर उसके बाद इंदौर के अंदर हम लोगों ने, हमारा राष्ट्रीय अधिवेशन हुआ था एवाईकॉन, जिसके अंदर करीब 2000 डेलीगेट आए थे। बहुत ही व्यस्त कार्यक्रम था शिवराज जी का, लेकिन उन्होंने बोला नहीं, और ये वहां पर पहुंचे और विश्वास सारंग भी उस समय साथ थे। ऐसे ही नागपुर के अंदर जब एवाईकॉन हुआ तो भी माननीय शिवराज जी वहां पर थे और गडकरी जी उनके साथ थे वहां पर। अभी हाल आखिरी में आपने जो चित्र देखा सरदार जी लोगों के साथ, अपना आइसोकॉन जो है होने वाला है अभी, हमारे कान की सबसे बड़ा सम्मेलन जो कि अमृतसर में होने वाला है। डॉक्टर दीपक हल्दीपुर उसके प्रेसिडेंट इलेक्ट हैं, वो यहाँ पर मंचासीन है। माननीय शिवराज जी ने सहर्ष अपनी ये अनुमति दी है कि अक्टूबर में वे अमृतसर भी आएंगे और वहां पर उद्घाटन करेंगे। तो मैं समझता हूँ कि ENT फैटर्निटी का योगदान जो है हम लोग को प्रोत्साहित करने का बहुत बड़ा है, उनके लिए जोरदार ताली। देखिए, आपने आखिरी वीडियो में देखा था कि वो बच्ची का माथा चूमने के पहले क्या बोले कि सारे लोगों को इकट्ठा कर लो कि ऐसा बच्चा छूट नहीं जाए। एक मानवीय संवेदना से भरे हुए आदमी मूक बधिर बच्चों के लिए, जैसे ही उनको मैंने एक बार बताया था तो उन्होंने 2014 में मुख्यमंत्री बाल श्रवण योजना की शुरुआत करी। उस समय हजारों बच्चों का कॉकलियर इम्प्लांट हुआ। वो प्रोग्राम उन्होंने जो शुरू किया था वो अभी तक चल रहा है और निरंतर जो है आबाद गति से ऐसे बच्चों को पुनर्जीवन मिल रहा है, जिसके लिए मैं माननीय शिवराज जी के हृदय से आभारी हूं कि उन्होंने इस प्रोग्राम को मध्य प्रदेश में शुरू कराया, जो पर ऐसे बच्चों को लाभ प्रदान किया। इसके साथ ही पर्यावरण की जहां तक सवाल है, 19 फरवरी 2000, आज से 6 साल पहले 2020 से पेड़ लगाना शुरू किया सर ने, और आज तक बिना नागा 6,000 पेड़ लगाए हैं, हमको उनसे प्रेरणा लेनी चाहिए। करोड़ों लोगों ने उनसे प्रेरणा लेकर पेड़ लगाए और पर्यावरण को लाभ पहुंचाया। वर्ल्ड वॉइस डे पर आपने देखा, तो कहने का मतलब सामाजिक सरोकार रखने वाले में भी कल उनका एक वीडियो देख रहा था कि वो माता जी से भुट्टा खाने गए, भुट्टा खा रहे थे, माता जी धोखनी कर रही थी, तो उन्होंने खुद ही हाथ में लेके धोखना शुरू कर दिया उसको, और फिर भुट्टा उससे लेकर खाया। तो एक मानवीय संवेदना से भरे व्यक्ति, जिनके अंदर हमेशा उनके पद को देखते हुए वो हमेशा लोगों से विनम्रता से मिलते हैं, क्योंकि लोग कहते हैं ना कि ज्ञान आपको आगे बढ़ाता है, लेकिन विनम्रता आपको ऊंचा ले जाती है। और आज जिस कद पर शिवराज जी हैं, उससे मध्य प्रदेश को और हम सभी को उन पर गर्व है। माननीय विश्वास सारंग जी भी हमेशा से ईएनटी फैटर्निटी से जुड़े हुए हैं, और हमेशा जब भी कोई चीज होती, कोविड के दौरान दोनों लोग थे। हालांकि बड़े कैलाश सारंग जी जब पितृपुरुष शिवराज जी ने उनको, एक बार मुझे याद है कार्यक्रम के अंदर ये बोला था कि इनके अंदर तो माता का भी हृदय है, पिता का तो हृदय है, लेकिन माता जैसी करुणा भी उनके अंदर है। तब उस समय ये विधायक थे। उसके बाद कोविड में दोनों ने बहुत काम किया। विश्वास सारंग जी ने कोविड समिति बनी वहां पर, और ब्लैक फंगस के इलाज के लिए हम लोगों ने बहुत समिति बनाई, और शिवराज जी ने उसके अंदर वार फुटिंग पर काम किया। और उसके लिए मैं सतीश जैन जी को बहुत आभारी हूं उनका, कि सतीश जैन ने पूरे, आपको मालूम है, देश को ब्लैक फंगस के अंदर मॉडिफाइड डेंकर अप्रोच सिखाई, जिससे हजारों हजार मरीजों का जो है जीवन बचा। मैं माननीय विश्वास जी का भी हृदय से स्वागत करता हूं। हमारे दीपक हल्दीपुर जी, वो कर्नाटका बेंगलोर से आते हैं, जो आईकॉन के प्रेसिडेंट रहे पास्ट, और अमृतसर के अंदर जो है आइसोकॉन के प्रेसिडेंट बनने जा रहे हैं। बहुत ही प्रोफिशिएंट सर्जन, बहुत अच्छे दोस्त। जब भी हम लोग किसी प्रोग्राम करते हैं, मैं, संजय और दीपक हमेशा साथ रहते हैं। माननीय सतीश जैन जी के बारे में अगर मैं कहूँ तो ये जैसे कहते हैं ना कि सूरज को दीपक दिखाने के बराबर होता है। बहुत शाय हैं, बड़ी मुश्किल से स्टेज पर बैठे हैं, लेकिन ओटी के अंदर वो कितने ज्यादा चपल हैं, ये आप लोगों ने कल देखा। कल उन्होंने, माननीय मुख्य अतिथि जी, मैं आपको बताना चाहूंगा कि 6 सर्जरी करी। एक सर्जरी ऐसी जिसमें एक महिला के दिमाग का पानी जो है नाक से बाहर बह रहा था, उसको इतनी खूबसूरती से डेमोन्स्ट्रेट किया कि सारे डेलीगेट जो है मंत्रमुग्ध हो गए। और मुझे लगता है इस तरीके के ऑपरेशन वो अगर करेंगे तो उसके अंदर एक तो रिफाइनमेंट होगा जो कर रहे हैं, क्योंकि जो उन्होंने टेक्निक बताई वो बहुत ही अच्छी है। इसके अलावा ईयर सर्जरी, इसके अलावा थायराइड की घेंगा, एक बहुत बड़ा महिला का घेंगा था, उसके रोग की सर्जरी, ऐसे करके 6 ऑपरेशन किए। आज भी 2 ऑपरेशन जो है नेजल पॉली पे जो मस्से होते हैं वो प्रस्तावित हैं, जो माननीय सतीश जैन जी करेंगे। सतीश जैन जी, आप इस कार्यक्रम में आए, इतनी अच्छी सर्जिकल स्किल दिखाई, आपका बहुत बहुत आभार। हम लोग हमेशा आपसे सीखते हैं। संजय अग्रवाल जी, आप जानते हैं कि जितने भी 19 बैक टू बेसिक प्रोग्राम हुए, सब में मेरे को ऑर्गेनाइजर रहे, मेरे बहुत अच्छे दोस्त, मेरे सखा। हालांकि वो इंदौर से हैं, लेकिन जब मैं कॉन्फ्रेंस में कई बार जाता हूँ तो लोग मुझसे ये कहते हैं कि आप इंदौर से हैं ना, क्योंकि मैं और संजय हमेशा कॉन्फ्रेंस में साथ दिखते हैं। अगर एक नहीं है तो दूसरे के बारे में पूछा जाता है। मैं आपका भी बहुत आभार व्यक्त करता हूँ कि आप यहाँ पर हैं। विनेश जुवेकर जी मुंबई से आए हैं, जो कि हमारी फैकल्टी हैं। विनेश जुवेकर जी जो है बहुत ही अच्छे तबला वादक हैं सर, और मुंबई हॉस्पिटल के अंदर जो है तो बहुत ही प्रोफिशिएंट ईयर सर्जन है। इसके अलावा राजीव पचौरी जी हमारे यहाँ पर बैठे हैं, जो कि आगरा से आए हैं, जो हमारे आइसोकॉन जो है, हमारा इस बार कॉकलियर इम्प्लांट की जो राष्ट्रीय वर्कशॉप है वो राजीव पचौरी जी कर रहे हैं। मैं उनका बहुत बहुत स्वागत करता हूँ। इसके अलावा हमारे मध्य प्रदेश के जो प्रेसिडेंट और सेक्रेटरी यामिनी गुप्ता और यशवीर यहाँ पर बैठे हुए हैं, मैं उनका भी नितिन श्रीवास्तव बैठे हुए हैं, मैं इनका भी बहुत ही हृदय से स्वागत करता हूँ। मेरे बहुत ही वरिष्ठ, मेरे संरक्षक जिसे कहते हैं, डॉक्टर सतपथी और डॉक्टर बुधवानी जो हैं, वो अपना व्यस्ततम समय निकाल कर इतनी सुबह सुबह यहाँ पर आए, मैं उनका बहुत स्वागत करता हूँ। सारे सीनियर जो ईएनटी सर्जन्स यहाँ पर हैं, मैं उनका स्वागत करता हूँ। मेरे जूनियर बच्चे जो कि विभिन्न कॉलेजों में पढ़ते हैं और जो बहुत एंथुजियास्ट हैं, कल इस हॉल के अंदर हम लोगों ने 100 लोगों की व्यवस्था करी थी, लेकिन 150 लोग आ गए सर। सतीश जैन की सर्जरी का ऐसा जादू था, और उन सब बच्चों ने सीखा। तो मैं आप सभी का बहुत ही हृदय से आभारी हूँ कि आप माननीय मुख्य अतिथि लोगों ने अपने व्यस्ततम कार्यक्रम में से समय निकाला। अभी विश्वास जी को जाना है प्रोग्राम में, और माननीय शिवराज जी को भी तिरंगा यात्रा में जाना है, लेकिन तो भी ईएनटी के प्रति उनका जो कमिटमेंट है, मैं उसको सलाम करता हूं। और हम लोगों को जो आप प्रोत्साहन देते हैं उसके लिए मैं आपको सलाम करता हूं। बहुत बहुत धन्यवाद।
धन्यवाद सर। डॉक्टर दीपक हल्दीपुर ने पिछले कई वर्षों में ट्रस्टवेल हॉस्पिटल को हम ईएनटी सर्जन्स के लिए एक तीर्थ का स्थान बना दिया है। सर अमेरिका से ह्यूमन कैडेवरिक हेड्स इंपोर्ट करके बैंगलोर मंगाते हैं। इस कार्य के लॉजिस्टिक्स को यदि आप इमेजिन करके देखें, अमेरिका में परमिशन लेना, कस्टम्स क्लियर कराना, इंडिया में परमिशन लेना, अमेरिका से लेके ट्रस्टवेल हॉस्पिटल्स तक कोल्ड चेन को मेंटेन करना, ये दीपक सर के अलावा और कोई कर नहीं सकता। सर देश भर से पायनियर्स को बुलाते हैं जो कि उन कैडेवर्स पे डिसेक्शन करते हैं और सबको वीडियोस सर सर्कुलेट करते हैं, यूट्यूब पे अपलोड करते हैं, जिनको देखकर हम जैसे सर्जन्स काफी कुछ सीख पाते हैं। सर ने कल मुझसे कहा था कि मेरे पास भी वही 10 उंगलियां हैं जो तुम्हारे पास है, तो अगर मैं कर सकता हूं तो कोई भी कर सकता है। मैं देश विदेश की इतनी कैडेवरिक डेमोन्स्ट्रेशंस अटेंड कर चुका हूं, मैंने ट्रस्टवेल हॉस्पिटल जैसी कोई नहीं देखी। सर जब भी वर्कशॉप अनाउंस करते हैं उसके अगले दिन सारी सीट्स बुक हो जाती हैं, क्योंकि जो एक बार जाता है वो पुनः वहां पे जरूर जाता है। सर की कल वेडिंग एनिवर्सरी थी, उसके बावजूद सर हमारे इस प्रोग्राम में आए। मैं सर से निवेदन करूंगा कृपया मंच पर आकर कुछ शब्द कहें। सर के लिए जोरदार तालियां।
हम सबको याद है इंदौर में जहां मैं प्रेसिडेंट था, एक ही नाक के ऊपर एक साइड सतीश ने फेस की और दूसरी साइड जानकी ने की। तो जब शिवराज जी आए, रवि रामलिंगम प्रेसिडेंट बनने वाला था और मैं वो हैंडओवर करने वाला था, और मेरे साथ सतीश बात कर रहा था, वो स्टेज पे, रिकॉर्डिंग अभी भी है। और शिवराज जी मेरे तरफ आके मेरे को हक किए, मैं बात करते ही जा रहा था। आज तक मुझे गालियां मिलती है घर में। मेरे पापा 93, माय मदर इज 88 and my wife, she says, Shivraj ji was so sensitive as a sitting CM and you were so insensitive you're talking to। एक तरफ गुरु और एक तरफ मुख्यमंत्री, मैं दोनों के बीच में अटका हुआ था। संजय will remember the incident, Satu will remember the incident। Really, a cultured chief minister, a cultured politician should be like Shivraj ji। You know, when I, see on the World Yoga Day, International Yoga Day, one of the few political leaders who can do all the yogas comfortably, क्योंकि हमारा कर्नाटक के सीएम तो ऐसे लड़खड़ा रहे थे, आदत नहीं थी उनको खड़ा होने का भी। जब कुछ डेमो के लिए करते हो, and when it is some part of your culture, Satu knows, it's not that I praise politicians or I like politicians, but there are some people who are above this. And to me, with my limited interaction with Shivraj ji, I can see that. It's a fantastic function. I won't take a lot of time because one is Shivraj ji. Next, Sarang ji, Vishwas Sarang को तो मैं हमेशा इधर मिला हूँ। One thing is I like his topi. I should wear one because I don't have hair. Second, the smile that he has. Third, I met his father during the first inaugural function. Satish Jain के बारे में क्या बोलूं मैं आज, whatever I am today, in these 14 years, from an unknown fellow, if everybody knows a Deepak Haldipur, if one man has a very big role to play, it is Satish. Yesterday I told him, first time I see both our photos together, I am so happy about it. It is much bigger than being the president of AOI or becoming the president of ISO. Or Sanjay and Sattu, I can only quote that line from a Hindi song because I'm not so good in Hindi as Sattu is. Uski Hindi to, it is poetry. ये रिश्ता क्या कहलाता है, I don't know. And the second line from another song, ये कहाँ आ गए हम यूं ही साथ साथ चलते. That's all is what I can say. Thank you very much and thanks to everyone. I think more than Karnataka, if a state which has given me maximum love, it is Madhya Pradesh. पता नहीं क्या संबंध है, क्या जन्म का नाता है, I don't know that. And the state which taught me the most is neither Bombay, nor Chennai, nor Delhi. It is Jaipur, Rajasthan. Thank you.
मैं निवेदन करूंगा हमारे मुख्य अतिथि मामा शिवराज सिंह चौहान सर से, विश्वास सर से कि वे शॉल श्रीफल से डॉक्टर दीपक हल्दीपुर को सम्मानित करें। सर के लिए एक बार जोरदार तालियां। धन्यवाद सर। कल ऑपरेशन थिएटर में जब सतीश जैन सर जिस कुर्सी पे बैठ के मैं हर दिन सर्जरी करता हूँ उस कुर्सी पे बैठ के ऑपरेट कर रहे थे, मेरे हाथ कांप रहे थे। मैंने जीवन में पहली बार सतीश सर को तकरीबन 2 साल पहले उदयपुर में एक बार एक केस के लिए असिस्ट किया था। मैं मामा को बताना चाहूंगा, मामा एक बच्चा था 15 साल का, उसके नाक में ट्यूमर था। वहां पे सारे डॉक्टरों ने कहा था कि इसके चेहरे को बीच में से काट कर उसका ट्यूमर निकालना पड़ेगा। मैंने उस बच्चे को कहा था कि जयपुर में डॉक्टर सतीश जैन है, आप एक बार मिल के आइए। डॉक्टर सतीश जैन ने कहा मैं इसको एंडोस्कोपी के लिए ऑपरेट करूंगा। जेएनए का पेशेंट था, 15 साल का बच्चा था। और जैसे फिल्मों में दिखाते हैं आखिरी में ट्विस्ट आया। सतीश जैन सर जब ओटी में आए तो उनके पैर में फ्रैक्चर था। उनका फ्रैक्चर देख के मेरा ऑन्को सर्जन बोलता है कि यार इनका तो पैर टूटा हुआ है, ये कैसे ऑपरेट होगा। हमने सर को बताया नहीं था, हम इतने घबराए हुए थे। हमने 9 यूनिट ब्लड इकट्ठा करके रखा था। आप यकीन करिए, अपने एक पैर पे खड़े होके सतीश सर ने 1.5 घंटे के अंदर जेएनए का केस खत्म किया। वो बच्चा जिसका पहले हम चेहरा बीच में से काटने वाले थे, उसकी मूछें भी नहीं कटी और उसका ट्यूमर बाहर निकल गया था। इसके अलावा बहुत सारे अच्छे सर्जन से मिलने का सौभाग्य मिला। एक अच्छे सर्जन के पास एक बड़ा दिमाग होना चाहिए, मगर एक अच्छे टीचर के पास एक बहुत बड़ा दिल होना चाहिए। मेरे सतीश सर के पास दोनों चीजें हैं। सर ने अपने वीडियोस के माध्यम से हम जैसे स्टूडेंट्स को इतना पढ़ाया है जिसको देखकर हम अपनी सर्जिकल स्किल्स को रिफाइन करते हैं, अपने मरीजों को बेहतर चिकित्सा दे पाते हैं। मेरे जितने भी मरीज हैं जो मुझे थोड़ी बहुत दुआएं देते हैं, उनका एक बहुत बड़ा हिस्सा मेरे गुरु डॉक्टर सतीश जैन को जाता है। और मैं अकेला नहीं हूं, मेरे जैसे ऐसे हजारों ईएनटी सर्जन्स हैं जो सतीश सर के वीडियोस से अपने मरीजों को बेहतर सुविधा देते हैं। उनके लाखों करोड़ों मरीज प्रतिदिन सर को दुआएं देते हैं। मेरे गुरु की उम्र लंबी हो, उनकी चरण धूलि से मेरी ओटी पवित्र हो गई। मैं सर से निवेदन करूंगा मंच पर आकर कुछ शब्द कहें। सर के लिए एक बार जोरदार तालियां।
हमारे माननीय मुख्य अतिथि सर श्री शिवराज सिंह जी चौहान साहब, माननीय विश्वास सारंग साहब और मंच पर उपस्थित सभी अतिथिगण और यहाँ मौजूद सभी बड़े छोटे सभी को मेरा नमस्कार। और सभी ने आपने जो कल से यहाँ पे जो प्यार दिया इसके लिए बहुत बहुत धन्यवाद। और विशेष रूप से डॉक्टर दुबे सर को जिन्होंने ये मौका दिया और सब लोगों के साथ इंटरेक्शन का एक मौका मिला। थैंक यू सो मच सर, थैंक यू सो मच।
मैं निवेदन करूंगा हमारे मुख्य अतिथि शिवराज सिंह चौहान सर से और विश्वास सर से कि वे शॉल श्रीफल से मेरे गुरु को सम्मानित करें। सर के लिए एक बार पुनः जोरदार तालियां। विश्वास सर कहते हैं खिलाड़ी जब खेल के मैदान में विश्वास सर कहते हैं कि जब एक खिलाड़ी खेल के मैदान में उतरता है, कभी जीतता है कभी हारता है, परंतु वो व्यक्ति जो खिलाड़ी बन जाता है कभी नहीं हारता। एक सर का वीडियो है यूट्यूब पर जिसमें वो इम्यूनाइजेशन प्रोग्राम के ऊपर बातचीत कर रहे हैं। आपको अगर मौका मिले तो कभी देखना, आपको ऐसा लगेगा एक डॉक्टर इम्यूनाइजेशन प्रोग्राम के बारे में बातचीत कर रहा है। विषय वस्तु के अत्यंत गहन चिंतन के माध्यम से कोई व्यक्ति इस प्रकार की निपुणता प्राप्त करता है, वो चाहे कोरोना काल में साइकिल पर जाकर व्यवस्थाओं का निरीक्षण करना हो, वो चाहे म्यूकर माइकोसिस के वक्त एम्फोटेरिसिन एम्प्यूल इकट्ठा करना हो। हमारे अस्पताल में उस वक्त बहुत सारे म्यूकर माइकोसिस के केसेस ऑपरेट हुए, सतीश सर ने भी कई केसेस हमारे यहाँ ऑपरेट करे। उस टाइम पे एम्फोटेरिसिन बी की बहुत कमी थी, हमने सर से सहायता मांगी थी और सर ने ऐसी सहायता करी थी कि जब आखिरी में जब पैंडेमिक खत्म हुआ और हमने मेडिकल स्टोर चेक किया था तो उसमें एम्फोटेरिसिन के एम्प्यूल बच गए थे। सर ने और उनके पिता ने मेरे अस्पताल का उद्घाटन किया था, उन्हीं के आशीर्वाद की वजह से शायद आज हम अपने मरीजों को सेवा दे पा रहे हैं। मैं उनसे निवेदन करूंगा मंच पर आकर कुछ शब्द कहें। सर के लिए जोरदार तालियां।
आज के इस कार्यक्रम में हमारे बीच में उपस्थित देश के कृषि एवं ग्रामीण विकास मंत्री और जिन्होंने संवेदनशीलता को राजनीति में वो स्थान दिया है जो हम जैसे छोटे कार्यकर्ताओं को प्रेरणा का काम करता है, ऐसे हम सबके नेता आदरणीय शिवराज सिंह चौहान जी, आदरणीय दीपक जी, आदरणीय सतीश जैन साहब, और अब दीपक भाई ने तो गाने की लाइन सुनाई, मैं दोनों के लिए एक शेर सुना देता हूं। डॉक्टर सत्तू दुबे के लिए और डॉक्टर अग्रवाल साहब के लिए एक शेर सुना देता हूं। किसी ने कहा है कि यारों किसी माहौल में ढलता नहीं हूं मैं, यारों किसी माहौल में ढलता नहीं हूं मैं, ठोकर लगे तो राह बदलता नहीं हूं मैं, रख दूं जहां कदम तो नए रास्ते बने, और खींची हुई लकीर पर चलता नहीं हूं मैं। सही मायने में ये दोनों की जोड़ी, कहा जाता है कि पैसा इकट्ठा करोगे तभी बढ़ता है, और ये बात सही है। हमारे शास्त्रों में लिखा है, सनातन दर्शन का ये बेसिक है कि पैसा जोड़ोगे तो बढ़ता है और ज्ञान बांटोगे तो बढ़ता है। तो ये दोनों डॉक्टर अपने ज्ञान को और ऐसे लोग जो कि इस विधा में बहुत निपुण हैं, उनके ज्ञान को लगातार इस प्रोग्राम के माध्यम से यंगस्टर्स को फैला रहे हैं। मैं दोनों डॉक्टर्स को बहुत बधाई देता हूं। कहा जाता है कि पिता अपने बेटे को सब कुछ सौंपने की कोशिश करता है, आदर्श पिता वही होता है। तो एसपी से डीपी की यात्रा, एसपी मतलब सत्य प्रकाश दुबे और डीपी मतलब दिव्य प्रकाश दुबे। तो डॉक्टर साहब ने युवा दुबे को ईएनटी भी सिखाया और अच्छा बोलना भी सिखाया। एक बार जोरदार ताली बजाइए युवा हमारे डीपी दुबे के लिए। ये मैं इसलिए नहीं कह रहा कि उन्होंने मेरी तारीफ की, नहीं तो आप कहोगे कि ये कहानी वही चल रही कि तुम मुझे नीरज कहो मैं तुम्हें निराला कहूं। आज के इस कार्यक्रम में हमारे बीच में उपस्थित आदरणीय हमारे हम सबके डॉक्टर सतपति साहब, डॉक्टर बुधवानी साहब, मेरे बड़े भाई अतुल कटारिया साहब, यशवीर हैं हमारे भोपाल की शान, और बहुत वरिष्ठ पत्रकार अनुराग अमिताभ जी, देश भर से पधारे हुए सभी डॉक्टर्स को, मनोज शर्मा जी भी यहाँ बैठे हैं, सबको मैं बहुत प्रणाम करता हूं, और डॉक्टर दुबे को बहुत बधाई देता हूं, और हमारे संजय अग्रवाल साहब को भी बहुत बधाई देता हूं। बहुत प्रसन्नता की बात है कि ये दोनों की जोड़ी और उसके साथ दीपक जी मिलकर इस विधा को पूरे देश में कैसे कुछ हम आगे बढ़ा सकते हैं इसके लिए लगे हुए हैं। सही मायने में सबसे महत्वपूर्ण है, किसी भी व्यक्ति के लिए जो सबसे बड़ा धन है वो निरोगी काया। और ये बात सही है कि जब हम पीड़ित मानवता की सेवा की बात करते हैं तो डॉक्टर वो वर्ग है, वो सेगमेंट है जिन्होंने कोविड के समय ये दिखाया है कि किस तरह हिंदुस्तान का ये सेगमेंट समाज की सेवा के लिए लगा हुआ है। निश्चित रूप से डॉक्टर सतपति दुबे जी ने इस विधा को आगे लगातार आगे बढ़ाया है। और वो कुछ जैसे कॉकलियर इम्प्लांट की हम बात करें, मैं माननीय शिवराज सिंह चौहान जी को बहुत धन्यवाद देता हूं कि उन्होंने, जब वो मध्य प्रदेश के मुख्यमंत्री थे, तो वो बच्चे जो कि सुन नहीं सकते थे इसलिए बोल नहीं सकते थे, उस मैं पूरी तरह से सरकार की मदद के माध्यम से उन बच्चों को बोलने लायक बनाया। ये निश्चित रूप से उनकी संवेदनशीलता का प्रमाण है और सत्तू दुबे की जीवटता का प्रमाण है कि उन्होंने शिवराज जी को इसलिए तैयार किया कि सरकार के माध्यम से ऐसे बच्चों को चिकित्सीय बैकअप मिल सके। हम सब मिलकर लगातार समाज की सेवा करें, ये अपेक्षित है। और मेरा मानना है, मैंने पहले भी इस कार्यक्रम में कहा है कि मैं ये मानता हूं कि जिस प्रकार से आप मरीजों का पर्चा लिखते हो, जिस प्रकार से डॉक्टर्स मरीजों का प्रिस्क्रिप्शन लिखते हैं, ऐसे ही भगवान ने हमारा भी प्रिस्क्रिप्शन लिखकर भेजा है। मैंने अपने ऑफिस में अपनी कुर्सी के पीछे लिखा हुआ है, प्रभु आपकी कृपा से सब काम हो रहा है, करते हो तुम कन्हैया मेरा नाम हो रहा है। मेरा मानना है कि इट इज ऑल प्रिस्क्राइब, जो जहां आया है, जिस स्थान पर आया है, ये सब भगवान का दिया हुआ आदेश है। और डॉक्टर्स, मुझे लगता है सबसे बड़े सौभाग्यशाली हैं कि आपको भगवान ने वो काम दिया जिसके माध्यम से आप पीड़ित मानवता की सेवा कर सको। तो मैं तो ये मानता हूं कि आपका अगला 7 जन्म भी भगवान सिद्ध करके भेज रहा है और आप उस नोवेल काम में, उस बहुत ही आदर्श काम में लगे हुए हैं। और आप कहीं केवल इलाज नहीं करते बल्कि लोगों की दुआएं भी लेते हैं। ये केवल मरीज से नहीं, मरीज के अटेंडेंट के माध्यम से पता लगता है। तो इसलिए मैं आप सबको बहुत शुभकामनाएं देता हूं। परमपिता परमेश्वर से, धन्वंतरी भगवान से प्रार्थना करता हूं कि आपके हाथ में ऐसी कला आए, इस तरह की सफा आए कि आप हर पीड़ित मानवता की सेवा कर सके। हम भाई साहब तो बहुत बड़े नेता है, मैं तो बहुत छोटा कार्य करता हूं, पर हम नेताओं को हर जगह बुलाया जाता है। डॉक्टर साहब सतीश जी, सतीश जी का कितना अच्छा मामला है, पिंक सिटी से सिटी ऑफ लेक्स में आए। हमारे यहाँ झीलों का शहर कहा जाता है। सतीश जी आमतौर पर, जैसे मैंने कहा, भाई साहब तो बहुत बड़े नेता हैं, मैं तो बहुत छोटा हूँ कार्यकर्ता, पर भाई साहब को बड़े बड़े प्रोग्राम में बुलाया जाता है, छोटे मोटे में मुझे भी बुलाया जाता है। अब हम, और एक विधा चल गई है कि कपड़े की दुकान का उद्घाटन, मैं अपने लिए बोल रहा हूँ, तो नेता को बुलाओ। उनका, यदि रेस्टोरेंट का उद्घाटन है तो नेता को बुलाओ। हम जैसे छोटे को कभी कभी नाई की दुकान के उद्घाटन में भी बुला लेते हैं। तो जब रेस्टोरेंट के उद्घाटन में बुलाते हैं तो हम बोलते हैं कि रेस्टोरेंट ज्यादा चले। हमें जब कपड़े की दुकान के उद्घाटन में आते हैं तो हम ये दुआ देते हैं कि कपड़े ज्यादा बिकें। यदि नाई की दुकान के उद्घाटन में तो हम बोलते हैं ज्यादा लोगों की हजामत बनाओ। पर यदि डॉक्टर्स के प्रोग्राम में ये बोल दिया जाए कि आपको ज्यादा मरीज मिले, तो हम लोगों को कोई वोट ही नहीं देगा। पर हम जब किसी डॉक्टर्स के या किसी हॉस्पिटल के उद्घाटन के कार्यक्रम में जाते हैं तो हम दुआ करते हैं। हम ये नहीं बोलते कि आपके पास ज्यादा मरीज आए, हम दुआ करते हैं कि आपके पास जितने आए वो ठीक होके जाएं, स्वस्थ होकर जाएं। तो मैं आज आप सब डॉक्टर्स को यही भगवान से प्रार्थना करूंगा कि आपके पास जितने मरीज आए वो सकुशल ठीक होकर जाएं। डॉक्टर सतीश के बारे में जैसा डीपी ने कहा कि उनके हाथ में तो भगवान ने वो कला दी है, तो वो कला और आगे, बल्कि आपके माध्यम से सभी यंगस्टर्स में, जैसा डॉक्टर एसपी दुबे ने बोला कि बहुत सारे स्टूडेंट भी यहाँ पर उपस्थित हैं, तो उनको भी ये विधा मिले। भगवान से यही प्रार्थना है, हम सब मिलकर एक स्वस्थ हिंदुस्तान का निर्माण करें, एक वैभवशाली हिंदुस्तान का निर्माण करें। हमारे देश के यशस्वी प्रधानमंत्री नरेंद्र मोदी जी ने सपना देखा। कल हम सबने स्वतंत्रता के 80वां वर्ष मनाया है, तिरंगा लहराया है और ये संकल्प के साथ भारत माँ का जयकारा लगाया है कि 2047 जब हमारे प्रधानमंत्री जी का सपना साकार होगा और 100 वर्ष की वर्षगांठ पर हम एक विकसित भारत का निर्माण करेंगे, एक शक्तिशाली, एक वैभवशाली हिंदुस्तान का निर्माण करेंगे, तो उस महायज्ञ में हमारी भी सार्थक आहुति हम दे सकें, एक स्वस्थ हिंदुस्तान का निर्माण करें। यदि स्वावलंबी हिंदुस्तान, विकसित हिंदुस्तान बनाना है तो निश्चित रूप से निरोगी हिंदुस्तान भी हम बनाना चाहते हैं, और वो सब यदि हो पाएगा तो आप जैसी वर्ग के माध्यम से ही होगा। इसलिए भगवान से प्रार्थना करता हूं कि आप और सफल हों और हम सब मिलकर एक शक्तिशाली हिंदुस्तान का निर्माण करें। डॉक्टर दुबे को, डॉक्टर संजय अग्रवाल जी को, दीपक जी को और पूरी टीम को मैं बहुत बधाई देता हूं और ये अपेक्षा करता हूं कि बैक से बेसिक्स ये जो कार्यक्रम है इसको और आगे लेके जाएं, पूरे देश में इस विधा की गूंज हो और इसके माध्यम से पीड़ित मानवता की सेवा हो। बहुत बहुत धन्यवाद। भारत माता की जय। हिंदुस्तान जिंदाबाद।
मैं निवेदन करूंगा कार्यक्रम के दोनों आयोजकों से कि वे हमारे विशिष्ट अतिथि विश्वास सारंग सर को शॉल श्रीफल से सम्मानित करें और उन्हें स्मृति चिन्ह भेंट कर सम्मानित करें। सर के लिए एक बार पुनः जोरदार तालियां। सत्ताईस जुलाई 2014 को जब मेरे अस्पताल का उद्घाटन हुआ था, उस दिन दैनिक भास्कर के फ्रंट पेज पे खबर छपी थी। मामा मुंबई में बिजनेसमैन लोगों के साथ मीटिंग में गए थे। मेरे पिता ने वो खबर देख के मुझे कहा था कि मैंने न्योता तो दे दिया है, पर मुझे लगता नहीं कि वो आएंगे। इतना बड़ा व्यक्ति हमारे छोटे से क्लिनिक के उद्घाटन में क्यों आएगा। थोड़ी देर बाद सायरन बजने लगे, हूटर बजे और कृष्ण भगवान सुदामा के घर आए। मैं एक मूक बधिर बच्चा जब सर्वप्रथम हमारे पास आता है तो उसके शरीर पे जगह जगह पे जख्म होते हैं। पूछने पे पता चलता है कि वो चल के जा रहा था, गाड़ी वाले हॉर्न बजा रहे थे, उसने सुना नहीं, उसे गाड़ी मार के चली गई, वो गिर गया। कोई उसे मार पीट के चला गया, वो उस मारने वाले का नाम नहीं बता पाता था। एक गरीब परिवार के लिए तो छोड़ दीजिए, एक मध्यम वर्गीय परिवार के लिए भी अपने बच्चे के दोनों कानों का कॉक्लियर इम्प्लांट करवाना असंभव तुल्य है। उन लाचार माता पिताओं की, उन मूक बधिर बच्चों की पुकार को सुनने वाले पहले व्यक्ति हमारे मामा थे। हम अक्सर लाडली लक्ष्मी योजना पे बहुत गर्व करते हैं, परंतु मामा ने एक ऐसी योजना बनाई थी जिसमें न केवल कॉक्लियर इम्प्लांट बल्कि पुनरावास के लिए जिस थेरेपी की आवश्यकता पड़ती है उसका भी प्रावधान रखा गया था। इन्हीं चीजों को देखते हुए महाराष्ट्र में जब राष्ट्रीय कॉन्फ्रेंस का आयोजन किया गया था तो सभी ईएनटी सर्जन विशेष रूप से भोपाल आए थे। मामा को लेकर गए थे कि उनकी योजनाओं को एक रोल मॉडल की तरह बाकी जगहों पर लागू किया जा सके। आइसोकॉन का पूरा डेलीगेशन अमृतसर से कम से कम 10-20 लोग दिल्ली गए थे मामा को सिर्फ न्योता देने के लिए, और यही इनकी लोकप्रियता है। हमने जब जहनुमा के लोगों को बताया कि मामा आने वाले हैं तो उन्होंने बोला ठीक है सर, हम अपनी तरफ से 20-25 सीट लगा देते हैं, मामा जब भी आते हैं तो बहनें ढेर सारी वैसे ही आ जाती हैं। इसके अलावा यदि मैं निजी जीवन से बात करूं तो एक डॉक्टर परिवार में पेरेंट्स अक्सर अस्पतालों में व्यस्त रहते थे। हम डॉक्टर बच्चों की परवरिश दादा दादी ज्यादा करते हैं। मेरे दादा ने मेरे अस्पताल का उद्घाटन नहीं देखा, उनका स्वर्गवास हो गया था। कोरोना काल के उपरांत मेरी दादी की मृत्यु हो गई थी। वो मेरे परिवार के लिए एक बड़ा ही कठिन वक्त था। उस वक्त पर मामा ने और विशेष रूप से मामी ने जो मेरे परिवार को संबल दिया था, जो स्नेह दिया था, उसके लिए मैं और मेरा परिवार सदैव उनका ऋणी रहेगा। मैं उनसे निवेदन करूंगा मंच पर आकर कुछ शब्द कहें। सर के लिए जोरदार तालियां।
दिव्य प्रकाश भी शब्दों के जादूगर हैं। आज के इस कार्यक्रम के विशिष्ट अतिथि मेरे स्नेही अनुज, मध्य प्रदेश सरकार के वरिष्ठ मंत्री, कल्पनाशील मस्तिष्क के धनी भाई विश्वास सारंग जी, अब यहाँ ऐसी हस्तियां बैठी है, मुझे तो पहली बार ये पता चला कि डॉक्टर इतनी बहुमुखी प्रतिभा के धनी होते हैं। अब दिमाग का पानी नाक में आ रहा है तो सर्जरी तो कर दें लेकिन शायरी भी सुना दें। आज के सुपरस्टार डॉक्टर सतीश जैन जी, जब एसपी कहते हैं तो मुझे अच्छा नहीं लगता, लेकिन सत्य प्रकाश बोलने में आनंद आ जाता है। बैक टू बेसिक्स जैसी कल्पना को साकार करके कैसे ज्ञान के प्रकाश को अधिकतम डॉक्टर्स तक पहुंचाएं, इस काम में लगे हुए। और सचमुच में अगर कोई मूक बोल ले तो उससे बड़ी सौगात उसके लिए कोई हो नहीं सकती। लगातार इस काम में लगे हुए हमारे डॉक्टर सत्य प्रकाश दुबे जी, और दीपक जी की तो बात ही क्या है। दीपक जी, हम तो अटल जी की एक कविता याद रखते हैं, भगवान इतनी ऊंचाई कभी ना देना कि औरों को गले लगा ना सके। भाई संजय अग्रवाल जी, हमारे गर्व और गौरव डॉक्टर सतपथी जी, बुधानी जी, यहाँ उपस्थित हमारे सभी मित्रों, बहनों, भाइयों, भांजे, भांजियों, अमिताभ अनुराग भी हम बैठे हैं। आज मेरा आना बड़ा संशय लग रहा था क्योंकि कार्यक्रम अलग अलग थे, लेकिन सत्य प्रकाश जी तुमने पुकारा और हम चले आए। तय किया कि थोड़ा तो टाइम निकालना ही है, लेकिन आज जब ईएनटी की बात करें तो गला बहुत महत्वपूर्ण है और आवाज में वो जादू होता है जो दुनिया का इतिहास बदल देता है। ऐसे ही आवाज के जादूगर, भारत के मुकुटमणि, करोड़ों करोड़ जनता के हृदय के हार, स्वर्गीय अटल बिहारी वाजपेयी जी की आज पुण्यतिथि है। मैं उनके चरणों में प्रणाम करता हूं। देश उनको सुनता था तो झूम जाता था। आप देखिए, एक भारत माता की आराधना करते हुए शब्दों को जैसे उनने पिरोया था और भारत माता के साकार स्वरूप को पूरे देश के सामने रख दिया था, वो उनकी आवाज का जादू था। उनने कहा था, ये देश हमारे लिए जमीन का टुकड़ा नहीं है, जीता जागता राष्ट्र पुरुष है। हिमालय इसका मस्तिष्क है, गौरी शंकर इसकी शिखा है, पंजाब और बंगाल इसके दो विशाल बाहु है, दिल्ली दिल है, विंध्याचल कटी है, नर्मदा करदनी है, पूर्वी घाट और पश्चिमी घाट इसकी दो विशाल जंघाएं हैं, कन्याकुमारी इसके पंजे हैं, सागर इसके चरण पखारता है, सूरज और चंद्रमा इसकी आरती उतारते हैं। ये ऋषियों की भूमि है, महर्षियों की भूमि है, ये वीरों की भूमि है, ये सूरों की भूमि है, ये अर्पण की भूमि है, ये तर्पण की भूमि है। हम जिएंगे तो इसके लिए, और अगर कभी मरना पड़ा तो मरेंगे भी इसके लिए। और मरने के बाद अगर हमारी राख गंगा जी में समर्पित कर दी गई तो वहां से भी एक ही आवाज आएगी, भारत माता की जय, भारत माता की जय। ये शब्दों का जादू है जो लोगों के मन में देशभक्ति का भाव भर देता है, और ईएनटी में ही वो सामर्थ्य है कि हम लोग भी इस आवाज से लोगों को बेहतर सेवा कर भी सकें और उसके लिए प्रेरित भी कर सकें, और ये काम आप कर रहे हैं। विश्वास कह रहे थे, बिल्कुल सच है। पहला सुख निरोगी काया। जब आदमी बीमार होता है तो बाकी कुछ ध्यान नहीं रखता, एक ही चीज, मैं कैसे स्वस्थ हो जाऊं, और तब डॉक्टर में ही वो भगवान के दर्शन करता है। और वैसे समय सही इलाज मिल जाए, सही दिशा मिल जाए और वो निरोग हो जाए तो सबसे बड़ा पुण्य का काम यही होता है। और ऐसे पुण्य के काम करने वाले सभी डॉक्टरों को मैं दोनों हाथ जोड़ के और शीश झुका के प्रणाम करता हूं। अगर हम संवेदना की बात करें तो संवेदना का मतलब, अगर किसी को दुख है, दर्द है, तकलीफ है, तो उसकी उस तकलीफ को आप अपने दिल में महसूस करें। उसके समान ही संवेदना। और मनुष्य का सबसे बड़ा गुण अगर कोई है तो वो है संवेदना। मैं जब मुख्यमंत्री था तो मेरा सबसे प्रिय काम था बीमारों का इलाज करवाना। बीमार ना हो ये कोशिश भी हम करते थे, योग दिवस से लेके बाकी सारे। लेकिन कोई अगर बीमार आ गया तो कहीं इलाज करवाना पड़े, सरकारी में, प्राइवेट में, भोपाल में, दिल्ली में, मुंबई में, मैं हमेशा कोशिश करता था कि वो निराश ना हो किसी भी कीमत पर, क्योंकि इससे बड़ी सेवा क्या हो सकती है। और आजकल भी अब मैं जुगाड़ करता हूं। कभी किसी से बात करता हूं कि इसके पैसे फलाने अस्पताल में जमा करवा दो, पैसे वालों से जुगाड़ करता हूं और अस्पताल वालों को परेशान करता हूँ, डॉक्टर साहब थोड़े कम में कर देना। इससे बड़ा पुण्य कुछ नहीं है सचमुच में। और इंसान का मतलब भी क्या है? डॉक्टर में तो लोग भगवान को देखते हैं, इंसान का मतलब है, मैं दो चीजें मानता हूं मित्रों, ये अंतरात्मा से कह रहा हूं। एक तो हम सब में एक ही चेतना है, यह भारतीय संस्कृति का मूल है विचार। एक ही चेतना जिसको तुलसीदास जी ने कहा सिया राम में सब जग जानी। सृष्टि के कण कण में भगवान विराजमान है, हर एक आत्मा परमात्मा का अंश है, हर एक घट में बस वो ही समाया हुआ है। तो दूसरा कौन है? दूसरा कोई नहीं, तो सबसे प्रेम करो। प्रेम जीवन की अमूल्य निधि है, अद्भुत है सच में प्रेम। तो एक तो सबसे प्रेम करो, और प्रेम का प्रकट रूप अगर कोई है तो वो है सेवा। अगर आप प्रेम करते हो तो कोई कष्ट में है, तो प्रेम का प्रकट रूप क्या होगा? आप उसकी मदद करो, आप उसकी सेवा करो। जीवन की धन्यता बस इसी में है। और विशेषकर राजनीति में मेरे विश्वास जैसे जो लोग हैं, हम तो यही मानते हैं कि जनता की सेवा ही भगवान की पूजा है। इसलिए दीन हो, दुखी हो, गरीब हो, सब अपने, दूसरा कोई है ही नहीं। और सचमुच में ये जो संवेदना है, ये मन को अपार आनंद से भर देती है। और आप तो संवेदनाओं के सागर है। मेरा निवेदन यही है, जितने भी हमारे विशेषज्ञ हैं, डॉक्टर सतीश जी भी यहाँ हैं, और बाकी मित्र भी, आप जो 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 ये प्रयत्न करते हो। अब डॉक्टर दुबे जी, संजय जी की बात कर रहे थे कि लोग कहते हैं कि ये दोस्ती हम नहीं छोड़ेंगे, लोग मिसाल देते हैं, उदाहरण देते हैं, लेकिन ये दोस्ती भी अच्छे काम के लिए। और इसलिए जब भी ये काम होता है तो मुझे कभी नागपुर बुलाते हैं, कभी अमृतसर बुलाते हैं, और मैं भी इसलिए आता हूं कि आप पवित्र काम में लगे, आप अच्छे काम में लगे हैं। यहाँ आके मैंने आप पे कोई एहसान नहीं किया, अपने आप को ही धन्य किया है। ऐसे पवित्र काम में हम सदैव सहयोग करते रहेंगे। अरे जीना उसका जीना है जो औरों को जीवन देता है। उससे बेहतर जिंदगी क्या हो सकती है? हमारे यहाँ तो ऋषियों ने भी गाया है। और पूरी दुनिया के लिए प्राणियों में सद्भावना हो, विश्व का कल्याण हो, वो हो, या सर्वे भवन्तु सुखिनः, सर्वे सन्तु निरामया, सर्वे भद्राणि पश्यन्तु मां कश्चित् दुख भाग भवेत्। सब सुखी हो, सब निरोग हो, सबका मंगल हो और सबका कल्याण हो, और सबको निरोग करने की जिस महायज्ञ में लगे हुए हैं, ऐसे सभी चिकित्सक मित्रों को मैं एक बार फिर हृदय से धन्यवाद देता हूं। बहुत बहुत धन्यवाद। जब जरूरत पड़ेगी मैं हाजिर रहूंगा। नमस्कार।
मैं निवेदन करूंगा कार्यक्रम के दोनों आयोजकों से कि वे हमारे मुख्य अतिथि मामा शिवराज सिंह चौहान को स्मृति चिन्ह भेंट कर सम्मानित करें। सर के लिए जोरदार तालियां। बैक टू बेसिक वर्कशॉप में आए गेस्ट फैकल्टी को मैं धन्यवाद देना चाहूंगा। मैं निवेदन करूंगा डॉक्टर मिनेश जुवेकर से कि वे कृपया मंच पर आए। सर के लिए जोरदार तालियां। मैं निवेदन करूंगा हमारे मुख्य अतिथि और विशिष्ट अतिथि से कि वे डॉक्टर मिनेश जुवेकर को शॉल और श्रीफल से सम्मानित करें। डॉक्टर राजीव पचौरी से मैं निवेदन करूंगा कृपया मंच पर आए। सर के लिए जोरदार तालियां। मैं निवेदन करूंगा आज के इस कार्यक्रम के आयोजक डॉक्टर संजय अग्रवाल से कृपया धन्यवाद भाषण से इस कार्यक्रम के समापन की घोषणा करें। सर के लिए जोरदार तालियां।
मैं दिव्य फाउंडेशन की तरफ से आभारी हूं माननीय श्री शिवराज जी का। और यहाँ मैं बताना चाहता हूँ कि अभी इंदौर में किसान सम्मेलन में साहब थे और हमारे यहाँ एक प्रोग्राम था, डॉक्टर जय कुमार आए हुए थे। तो सत्य प्रकाश बोला मैं सर से बात करके देखता हूँ। तो सर सहर्ष आए, हमारे बेटे का वॉइस क्लिनिक भी उद्घाटन किया, डॉक्टर जय कुमार के साथ प्रोग्राम में भी सम्मिलित हुए। विश्वास भाई उस दिन नहीं आ पाए थे। तो ऐसे हमारे मार्गदर्शक रहें तो हम क्यों ना आगे बढ़ें। मैं आभारी हूँ रमेश जी, हम उनको टेटवा करके बुलाते हैं क्योंकि वो सतीश जैन साहब के साथ हमेशा रहते हैं, ऑपरेशन थिएटर में मदद करते हैं, असिस्ट करते हैं। हम हमारे एनेस्थेटिस्ट डॉक्टर बाटी और हमारे फार्मास्यूटिकल सन फार्मा जो हमेशा हमें सपोर्ट करते हैं, उनका बड़ा आभारी हूँ। डॉक्टर दीपक तो मित्र ही हैं, उनका कोई आभार नहीं है। आभार है सब ईएनटी सर्जन्स का जो देश में अलग अलग स्थानों से आए हैं और इस कार्यशाला को सफल बनाया है। धन्यवाद।
इसी के साथ मैं इस उद्घाटन समारोह के समापन की घोषणा करता हूं। धन्यवाद।
सबको प्रणाम।
I request Dr. Sudhakar sir to please felicitate our chairpersons, Dr. Prakash Barfa sir, Dr. Nitish, and Dr. Ankit. Sir, I do sir felicitate. Sir, ye- Flags the flags दे दो वहां पे। I would like to invite Dr. Deepak Haldipur sir for delivering his talk on common problems in ENT practice. To chair the session, I request Dr. Tarun Gurjar, Dr. Ajay Patidar.
That makes it about roughly 41 years of practice, out of which 5 years, that is till 1990 February, it was better. So out of which 5 years was general practice after MBBS. I finished my ENT on, I think, February 27th of 1990, when my professor told me, unofficially, you have cleared your MS, your results will come in 10 days. I went to my senior and I told him, unofficially, I have passed, but official degree will come 10 days later. So we went to party. As we finished our third beer, he told me, "Arey, my hospital mein tomorrow there is one tonsillectomy. Tu karega?" I said, "Main karunga." And then next day morning, with unofficial degree, I did my first tonsillectomy. I didn't have a tonsillectomy set. I borrowed it from my senior that midnight at 11 o'clock, got it autoclaved next day morning, and did the first tonsillectomy. So whatever talk I'll be doing here will not be from any journal, any book, any publication. It is only what I do in my practice. I want to share it with a few juniors. I have a few compulsions. I practice between 7:30 to 5:30. I have a small team of 11 ENT surgeons with me. We do between 2 to 6 cases per day. And we run parallel individual OPDs. And I need to see at least about 60 to 72 outpatients in a day. So you roughly have about 7 minutes per person to sort out a case. So I've formed my own algorithms in managing cases, and I would like to share just 4 topics, each for 10 minutes. I think Sattu's phone is ringing. The first poorly treated case that I see in ENT even now is vertigo. Somebody comes with recurrent attacks of vertigo, audiometry shows unilateral SN loss, immediately they make a diagnosis of Meniere's. And I have seen, because मेडिकल प्रैक्टिस में 15-30 साल के बाद गधा भी घोड़ा बन जाता है. So I keep getting 3rd reference, 7th reference, 8th reference. If ENT surgeons have made 10 diagnoses of Meniere's, usually 1 or 2 cases actually has Meniere's. Remaining had vertigo with SN loss, unconnected to each other. So the moment a person comes to you with vertigo, history is most important, because many times people have been treated for vertigo. When you take the correct history in their own language, many of them mean vague sensations like heaviness of head, tension in the head, All these were being treated with all available vertiginous drugs on the planet. I asked them the history of first attack, whether it is really giddiness or lightheadedness or heavy-headedness or headache, whatever. Unsteadiness, I would like to know the frequency of the history, the duration, hearing loss, whether it is associated with tinnitus. But let us forget all this. Remember one simple point. If 100 patients come to any doctor of any specialty with vertigo, 85% of them are otogenic. This is indisputable. 4% is migraneous vertigo or vestibular migraine. 2% is psychogenic, functional, or fear of vertigo. In the remaining 4%, 3% is because of all the lows. Low BP, low sugar, low vitamin D, low vitamin B12, low hemoglobin, or low heart rate, which you can detect by a Holter valve monitoring. Maybe out of 400 cases, one case is due to some tumor in the brain or some acoustic neuroma or something, and one is due to cardiac vertigo, where it is very important to do a tilt table test and Holter valve monitoring. Now we have a wonderful tool, the CT coronary calcium score. Simple test can detect many heart ailments giving rise to vertigo, who are being given tons and tons of sinerizine, betahistine, and meclizine, and what all and what not. And again, in that 85% of the otogenic vertigos, 80 to 85% is benign paroxysmal positional vertigo. And in that benign paroxysmal positional vertigo, 80 to 85% is a posterior canal vertigo. So if you know one Epley's maneuver properly, you can treat 64% of all the vertigos in the world perfectly. And I tell you, 85% of the ENT surgeons all over the country still don't know how to treat a proper benign paroxysmal positional vertigo. That is why most of our patients have idiopathic vertigo or chronic vertigo, which are synonyms of the same name, idiot doctor and pathetic patient. This is a simple, plain truth. When patient comes and tells you, sir, I got giddiness episodes 3 times last 1 month, or he comes back to you again after 2 months and says, I've got 3 more episodes. How many of you tell him that during the attack, please take a selfie video with your eyes open, or ask one of the closest attendant to take a selfie video with the patient's eyes open? That nystagmus can give you much more diagnosis than all your VNG, stabilometry, rotation chair, falana, dinka. Even now, a vertigo can be easily diagnosed this way. One more thing, whenever a patient comes to you with recurrent vertigo or chronic vertigo, first withdraw all the drugs. If the patient has taken a betahistine tablet yesterday or sinerizine, your DREM test, there's a short term I coined, Dix-Hallpike, roll test, extended head hanging test, and finally maneuver. This I call it as DREM, DREM. So Dix-Hallpike will tell you about BPPV posterior canal, roll test about the horizontal canal, extended head hanging test about the superior canal, which is rare, but I've seen 2 cases. This doesn't require a VNG machine, it doesn't require an ENG machine. Our treatment is still pathetic. That is my take on vertigo. Migraneous vertigo is becoming very, very common. I have seen young people, young patients who develop migraine at the young age, the moment they turn around the age of 40 or 50, headache is no longer the presentation. It starts presenting itself as vertigo. And migraine is vertigo like skull-base osteomyelitis. What the mind does not know, the eyes cannot see. Migraine vertigo is a chameleon. It can present itself in any way. Only if you suspect, and the repeat video recordings of the nystagmus by the patient or the attendant and the history is the clincher, and you can diagnose this. Because diagnosis is the key. Treatment is very easy. Phobic and functional vertigos are very common. I get a lot of them. People, 1 or 2 attacks, they get so scared that they keep on fearing they may fall. It's very important to keep this in mind. As I told you, Meniere's is overdiagnosed. Meniere's, typically the giddiness or the attack cannot go beyond 1 day. Next day the patient is fine. Patient never gets hearing loss before the onset of vertigo. And hearing loss comes much later, a few years later. The tinnitus comes up definitely 1.5 to 2 years later when it becomes continuous. Otherwise, it's not seen in the first few attacks at all. The typical fullness in 1 year before the onset of the attack, transient tinnitus, and a severe vertigo generally not lasting beyond half a day, where what starts in the morning. Associated with a delayed hearing loss shown after 2 to 3 years, and the attacks coming closer and closer with every event is a typical Meniere's. And I'm sorry to say this, it is unfortunately overdiagnosed. No proper history taking, no proper understanding of this. Chronic vertigo, I said, is idiopathic or iatrogenic because the treating doctor was not good at. I'll not go into central vertigo. We do a DREM test. I told you the video of nystagmus is extremely reliable. VNG, ENG, all these other high-tech gadgets, your ECOG-G, so on and so forth, have very limited value. Vertigo is still a clinical diagnosis. A good doctor who is adept at the vertiginous mechanism can diagnose most of it with a history and DREM. 99% of the diagnosis you can make. The other things I already mentioned, I won't spend time on that. Finally, in today's day, any slightest doubt when it comes to headache or vertigo or anything, please get an MRI done. Many a times without any symptom, any sign, any clue, diagnosis has come up. And ENT people, for some unfortunate reason, still stick to CT scan. One is exposure to a lot of radiation. As Satish Jain put it very clearly today, when it is a pathology, only MRI works. Then are you sitting there in a chamber to discuss physiology? Your CT scan at best can tell you only 3 things. 1, as a roadmap when you plan to do any surgery for anatomy. Number 2, when there's a gross erosion of the bone, it can tell you something is sinister. It's a difficult surgery. It cannot still tell you whether it's a malignancy or a benign lesion. And number 3, when done with contrast, it can give some information about head and neck malignancies. I have really moved around 90 to 93% of my investigation now is an MRI scan. If you want to be a businessman in ENT who wants to make money at any cost, you can rely on that machine called CBCT, cone beam CT. If you want to get into real cutting edge academics to be on the top of your game, go for MRI and MRI with different sequences, learn them well, which has to be ordered. This for the youngsters, because times are changing and they're changing very fast. Management, please remember, whenever a chronic or recurrent vertigo patient comes to you, first thing you do is stop all the medications Give some placebo. The best one is ondansetron, mouth dissolving. Give a gap of 10 days, 14 days. In some patients, after 8 months, I could locate the diagnosis or a nystagmus. It was a simple BPPV hidden under layers and layers of vestibular suppressants and antihistamines. My grandfather's family doctor, a family physician, came to me with a suicidal tendency because every time I bent to examine with a stethoscope, he would get a giddiness, and it was not diagnosed. My wife knows his name. He is Dr. M.P. Karki. He was also our local MLA after some time. All that we did was 2 months we withdrew all the beta histine, everything, to find that he had a simple posterior canal vertigo. One Epley's maneuver. He practiced happily for 4 more years and then passed away. If this is the vertigo treatment we are giving a doctor, you can imagine what treatment others are getting. Minesh says at times I'm very harsh. I don't know. This is what I feel. In Meniere's disease, when do you give intratympanic injection? Most of the Meniere's disease can be managed very well with a good diuretic. I use the combination of triamterene with spironolactone. The trade name is lacilactone. This doesn't cause any potassium deficiency. You don't need to give any pot chlor along with it. Only thing, the first 3 months when you use it, get serum electrolytes done every month. Just like an itraconazole, which has an all or none reaction, lacilactone is also very well tolerated by most of the patients. My instances and indications of giving intratympanic gentamicin have come down drastically after I've started using this molecule. Very rarely when a patient doesn't respond to any vertigo medication, I first try intratympanic dexamethasone. If that doesn't work, then I go for intratympanic gentamicin. Remember, one injection given stays in your endolymph for 23 days. So please don't repeat it till 21 days. The way to give it, dilute 1 cc of gentamicin in 5 ml of saline, pick a 26 gauge needle, make the patient lie down, inject it, and allow it to stay there for 20 minutes before the patient gets up. Don't turn the patient's head. Works wonders. Till date, I did not get a single case in my 36 years of ENT practice where I had to do a vestibular nerve section for intractable Meniere's. Maybe I just don't see enough patients, but that's what I feel. Diuretics, as I told you what I use, and vestibular rehabilitation exercises are very, very important in migrainous vertigo, phobic vertigo, and in Meniere's. Because of the vestibulopathy, these exercises are very important. The biggest advantage of a DREM in a BPPV, patient comes to you, you do a DREM, the nystagmus comes in your room, you do an Epley's maneuver, call them after a week or 14 days, do a follow-up DREM. Patient realizes in the same room, when I put my head to the right, 14 days back I had severe vertigo, and I don't have any now. So the phobic element or the psychogenic element of persisting vertigo disappears. This is my take on vertigo. I'll move to sudden sensory neural hearing loss. The other condition which is being treated very, very pathetically is a sudden sensory neural hearing loss. I get so many patients. Patient went to the ENT doctor with a ear block. Some oral decongestant was given. Nasal drops was given. Even an audiometry was not done in 60% of the cases. If you don't have access to the audiogram, please do the hum test, which I learned from my good friend, Dr. Manoj Manikot. It is a Otto Weber's. So when you have a ear block and there is no audiologist in the visibility, ask the patient to do very loudly with the eyes closed and ask him or her whether the voice is heard well in the affected ear or the opposite ear. If the patient hears his or her own voice with the eyes closed in the loud hum in the affected ear, it's a conductive loss. You can still wait, you have time. If he or she hears on the other side, straight away shoot methylprednisolone 1 gram IV 3 days. If you have good access to a diabetologist or a physician, admit the patient. There's nothing wrong in giving it in a diabetic also. Please don't treat half-heartedly. What annoys me, what upsets me is half-hearted approach to anything in life. Anything in life. If you have an access to audiogram, then be aggressive. My treatment, if the patient comes to me within 24 hours, I admit the patient. I give them 2 bottles of low molecular weight dextran in NS, each one going for 6 hours, and 1 shot of methylprednisolone, day 1. Of course, whenever you give methylprednisolone, before giving methylprednisolone, give an IV pantoprazole. Second day, you give 1 bottle of low molecular weight dextran, 1 methylprednisolone, and pantoprazole. And day 3, give 1 methylprednisolone, 1 pantoprazole, 1 low molecular weight dextran. In between, on day 1 and day 3 and day 5, also give intratympanic dexamethasone. It may be an overkill. What are you going to lose by putting dexamethasone in the middle ear? Nothing. If your own wife, your own son, your own child suddenly loses hearing, will you happily keep on yarning and farting and not doing an audiogram and giving a oral decussion? Would you do that? If an ophthalmologist, a patient comes to him with sudden loss of vision, you think he will take it very casually? Why are we ourselves not giving importance to this sudden hearing loss? Even today in my practice, I see 60 to 70% of these cases being treated with a half-hearted, lackadaisical approach. Audiologist nahi hai, aaj Saturday, Sunday, aaj August 15th hai, kal aa jao. And you know very well that the cause is mostly either viral or it is due to some infarct in the cochlear artery. And how would you treat an infarct elsewhere in the body? You think you'll wait for 10 days, 15 days? Sudden SN loss is one of the 2 otologic emergencies. In fact, the only otologic emergency. The second is skull-base osteomyelitis. Pathetic. So this is what I do. Later you can change your oral deflozocort and all that. Hyperbaric oxygen is another big scam in ENT. Last 36 years, I'm yet to see a single human being's hearing improve by 1 dB with that hyperbaric oxygen. And the other biggest scam in ENT is injecting that PRF intratympanically. I don't know. I don't blame the patients at all that they don't trust us anymore. Pathetic to say the least. The third commonest cases which I get nowadays, snoring, obstructive sleep apnea. How do I treat it? The moment patient comes to me, I do an examination of the throat to look for big tonsils. 7% of all the snoring patients, whether they have obstructive sleep apnea or not, are due to big tonsils. You do a good tonsillectomy, little work on the palate, they're fine. Another 7%, the problem is because of the nose. Only 7%. Because as I told yesterday in talk in Bangalore in Madhavaya's Golden Jubilee, instead of learning the correct surgeries, the difficult surgeries which give good results, all of us are busy trying to find indications to correct that slightest deviation of the nasal septum. It has come to a point where we may even attribute it to azoospermia. Pathetic to say the least. 7% only. How do you diagnose that? Nasal challenge test. Now you have a simple product, fluticasone with oxymetazoline. Any patient who comes to with snoring, ask him to take a sleeping video of 90 seconds in deep sleep. If the patient is alone, now you get those sleep softwares on the mobile where they can track their snoring for the whole night. Ask him to pick the point of peak snoring time. Take that audio clip, bring it to you. Then you start him on this combination of fluticasone with oxymetazoline. 14 days, 2 sprays to each nostril, morning and night. Unless the patient has an antroconal polyp or a nasal mass, even with the grossest deviation, this particular drug makes the turbinate shrink so beautifully. Repeat another scan, the video or the audio. If you see 60 to 80% reduction in snoring, sometimes 100% reduction in snoring, this snoring mainly is coming from the nose. These 7% patients are likely to do well with nasal surgery. You can confidently advise nasal surgery in these patients. Again, if the nasal obstruction is due to very bad allergic rhinitis, then also the snoring can disappear. So look at the color of the mucosa, smallest doubt, do an IgE, absolute eosinophil count. That negative, you can even go ahead and do an SPT. Make sure that this patient is going to benefit. Surgeries get a bad name not because the surgeries were done badly. The case selection was pathetic. Diagnosis was miserable. So now I ruled out 7% tonsil, 7% nose. What do we do with the remaining 84%? 30% is due to the shape of the jaw. Most of the women, the shape of the jaw is such, you compare 2 women of the same height, same weight, the man is snoring like a lion, the woman is not snoring at all, or it's just like a whisper. It is because of the configuration of the jaw. So the last 56%, the major chunk, is due to the sagging of the tissues with aging. The moment you reach the age of 30, your tissues are not the same. Number 2, you also realize obesity. Obesity is a big thing now. So a weight loss is what that can solve the problem. So this remaining category, that is only 14% of all the snoring patients will benefit with your surgery. 7 with a septal surgery, 7 with a tonsillectomy, or 14 with all the combos, septoplasty, turbinectomy, uvulopalatopharyngoplasty, all these things. The remaining 86% will benefit from weight loss, CPAP. Maybe 1 out of 200 or 300 will accept and get a maxillomandibular advancement done. That surgery is extremely rare. I usually do it in post-traumatic cases or people who are born with hemifacial microsomia or anomalies of the mandible, etc., where you can, the moment you see the patient, you can say, this face is abnormal. So simply doing septoplasty turbinectomy on 80% of the snoring patients, hoping and convincing the patient that the snoring will go, when it works only on 7% people. So the nasal challenge test I spoke, septoplasty, turbinectomy, tonsillectomy, palatopharyngoplasty, zeta expansion pharyngoplasty, tongue base reduction, maxillomandibular advancement. Remember, tongue base reduction gives very, very marginal benefit, not too much, and the effect is not long term. You will get a bad name. You will get a bad name. Now I come to the last topic, my favorite topic, skull base osteomyelitis. I think I'd asked for 40 minutes. I have another 20 minutes, so I'll just finish because I'm supposed to join one fire talk of Dr. Madevaya, but let me do justice to this first. What the mind does not know, the eye will not see. Today, our biggest enemy is neither Bangladesh nor Pakistan, as the politicians make us believe. The biggest enemy is diabetes mellitus. In Kannada, they used to say, maybe it is there in Hindi, ಊಟ ಬಲ್ಲವನಿಗೆ ರೋಗವಿಲ್ಲ, ಮಾತು ಬಲ್ಲವನಿಗೆ ಜಗಳವಿಲ್ಲ. A man who knows his food will never get disease. A man who knows how to talk will never get into a fight or an argument. So today in my Trustwell hospital, if 100 people are getting admitted to my ICU, my own statistics, 65% of people are getting admitted because Yashasvi, I'm on the stage. Another 20 minutes I'll be completing the talk, then I will join. I'm just giving an oration. Hello? Yeah. 65% of all the patients who get admitted in ICU are because of food. Any one of you in the hall, do you believe it is for starving? It is bloody because of overeating and the junk food. So the moment a patient comes to you anywhere beyond the age of 20, once upon a time we would see diabetes at 50, now we see it at 20. The moment the patient comes to with pain, typically starting at around 5 p.m. in the evening, gradually increasing to a crescendo by 11 in the night, starts coming down by 3 a.m. or 4 a.m. in the morning, and reduces substantially by 8 a.m. It is definitely either malignant otitis externa, which is the term you use when the canal skin is involved, or a skull base osteomyelitis when the disease has now entered the dangerous territory of the bone. Most of these patients, the commonest factor I found was that their HbA1c was much higher than their hemoglobin percentage. That was the excellent sugar control they had. The diabetes is poorly controlled. In a lot of people, you see a granulation or a polyp or a furuncle in the external aortic canal. But beware, nowadays I've been seeing about 3 to 4% of patients, the ear looks pristine, totally normal. The history is suggestive of SBO. And the only way I've diagnosed it is by an MRI with contrast and sometimes the additional input of CRP and ESR. So central skull base osteomyelitis, your ENT examination can look perfectly normal. This is also seen in patients apart from diabetics, patients who are undergoing dialysis, chemotherapy, people who are HIV positive, people who are severely anemic. It is very common. Investigations, please do a CRP and ESR. Please do a HbA1c. Don't rely on this FBS, PPBS business. It's obsolete. Today's diabetes, if as patients, you doctors are doing your FBS and PPBS, you are living in past. Please get your HbA1c, fasting insulin, and C-peptide every 3 months. This is for you people, for your own health. You do a creatinine so that you plan the drug dosage and the kidney status. A serum galactomannan if you're suspecting aspergillus infection. Not a very specific indicator, but an indicator all said and done. And don't keep on doing CT. CT bajana chhod do. It is MRI with contrast. That is the diagnosis. Now, one important point I want to tell about MRI contrast. At least in our practice, we were hesitant to advise a contrast study if the creatinine was around 1.3. The current Radiologist Association of US and they're coming up with a guideline that whatever may be the creatinine, there is no contraindication to do a contrast study. Because the only side effect of a contrast of an MRI is idiopathic subdermal fibrosis, which has been seen in the whites and the Caucasians. Not a single case has been reported in an Indian patient or a brown patient or a black. So please don't hesitate to do a contrast MRI. In fact, the radiologists have now coined a new term called renalism, which means for the fear of not doing a contrast, the number of diseases that were missed, improperly treated, have given rise to much, much more mortality and morbidity compared to the morbidity created by the contrast. So very shortly are coming up with the actual guideline, the American Radiology Association, that a contrast is not at all contraindicated in a patient whose renal parameters are not normal. We do culture sensitivity, very important. A culture swab taken from the pus is less accurate. A culture taken from the tissue is very accurate. Now we have a new NGS panel where if repeated pus cultures, tissue cultures come negative, the NGS panel gives you an idea of what antibiotics are likely to work. Some direction in a dark room, some feeble light. So this is an important investigation. Of course, you do a biopsy. Causative organisms, mainly bacteria, Staph aureus, Pseudomonas aeruginosa are the commonest. You can see some Klebsiella, E. coli, anaerobes, actinomycosis, very rare, easily treatable. Basically because Pseudomonas and Staphylococcus are the commonest biofilms. And I learnt a lot about biofilms after Kirtane sir made me give a talk 10 years back in 3 places. Otherwise, I didn't have a clue what was a biofilm. In fungi, commonly I see aspergillosis, which is easy to treat also because voriconazole is a good drug, well tolerated. Medical literature says it can be carcinogenic, but it is still debated. And sometimes now I am seeing mucor and some cases both mucor and aspergillus. Again, I have just divided into ventral, lateral and central. मेरा और 5 मिनट बाकी है उसको बोल. Okay. Satish, give me 5 minutes. I'll finish this. Ventral, lateral and central. Depending on the commonest variety is lateral, next is ventral and then the central. The way the skull base osteomyelitis spread, initial part of my career, I would do a lot of mastoidectomy, tympanoplasty, canal wall down to find that it was totally useless. This disease is anterior and inferior. It always attacks the tympanic bone. So it goes in and around the ICA, pterygopalatine fossa, infratemporal fossa, clivus, basis sphenoid, and basiocciput. The treatment modality and approach. Oral antibiotics are totally useless in treating skull base osteomyelitis and malignant otitis externa. Don't try your luck. Don't give tablets. Sink in a PICC line, PICC line. Your anesthetist or somebody will do it for you. That way you can give IV antibiotics for 12 weeks without any problem. Involve an endocrinologist, nephrologist, radiologist, neurologist, neurosurgeon, and ophthalmologist, and start IV antibiotic. If the culture is positive, give the appropriate antibiotic. The point where the pain disappears, give antibiotics for another 2 to 4 weeks. Don't stop at that stage. And ideally 2 antibiotics. Suppose the culture is negative, start straight away ceftazidime, 2 grams BD with levofloxacin, 500 BD, 3 weeks. Pain disappears, continue for 2 to 4 weeks. Pain doesn't disappear, change to meropenem, 3 weeks. Pain doesn't disappear, add oral voriconazole. Pain still doesn't disappear, go ahead with surgery. Your MRI in the first visit itself shows abscesses, sequestrum, go ahead with surgery. That is the algorithm. Follow up, do monthly MRIs with contrast, no need to hesitate. The moment the CRP comes down to about 8, you can be very sure the ESR comes to 36. If you want, you can be very sure the disease is completely dead. More to reassure. If you want, you can change to whole antibiotics. More to reassure. Rarely you can do a PET scan. You can do a galactomannan where it's a confirmed case of aspergillus for prognosis. Point for surgery, whenever the pain doesn't respond to medicine, cranial nerve palsies, scans show sequestrum and abscess, bone erosions, infarcts, carotid thrombosis, brain abscesses. So in this you have to do surgery. Surgical modalities, simple IND if it's a furuncle, excision of the canal granulations, myotoplasty, going down to the bone, removing the skin, mastoidectomy, tympanoplasty, obsolete, subtotal petrosectomy in certain cases. I don't do a blind sac closure in patients with SBO when I do subtotal petrosectomy. In more extensive diseases, infratemporal fossa A, B, C. When it is going towards the clivus, go through the ventral approach and do that as well. I'm coming to the last 2 slides. So this is just to show. Basically, all that you need is know your carotid anatomy very well. The only 2 things that you shouldn't do in a skull-base surgery: don't by yourself enter the dura, create a CSF leak. You are sending the infection intracranially. Number 2, don't damage the carotid. Otherwise, it is more like treating a cancer. Patient will accept any other complication, including a nerve palsy. Have a coarse, good diamond burr. Keep drilling till you meet healthy bone and healthy granulations. It is basically an extensive debridement. And in ventral skull base, yes, my alarm came, I finished my 40 minutes. In ventral, this is my last slide. In the ventral skull base, you go through the endoscope and basically drill out, do a proper fess. You can see me using the coblation on the keel, the sphenoid is open. The pus and micro abscess was here, you can see it opening up, and then you keep on drilling. Basically a good, nice diamond burr will do the trick for you till you come across healthy bone bleeding. What have we achieved with all this talk and all these things? 10 years back, if I got 10 cases of SBO, 9 would die, 1 would survive. Now confidently 7 survive, 3 may die. In a year's time, I feel it will be 9 and 1. 9 will survive, 1 may die. Even those persons who die, if you have done a good debridement, they die a painless death due to cerebral involvements, infarcts, and strokes. Not because of that excruciating pain. And less stability, facial palsies improve. The last slide, take home message, detect it early. What the mind does not know, the eye does not see. Be very aggressive in medical management. No tablets. Pick line first, IV medicines only. Precise, well-designed surgical treatment. Involve multidisciplinary people. Don't try to do everything by yourself. Appropriate and proper use of investigations. Pick line is most important. If you have access to a pain specialist who can manage the pain during this journey, life is easy for you. And above all, the worst thing that a doctor can tell any patient, isko kuch nahi kar sakta, isko kuch nahi kar sakte. Please do your best. Don't give a negative prognosis. Try to do your best. Most of the times you will succeed. What stops any human being on earth in achieving anything is the fear of failure. Please see the Mountain Dew advertisement 4 times a day. क्योंकि डर के आगे जीत है. Thank you.
I request Dr. Sanjay Agrawal sir to please felicitate Dr. Deepak. I request the chairpersons to please come on the dais. So next we have a surgical treat. That's a patient is 37 years old male, presented with complaints of bilateral nasal obstruction, headache, and post-nasal drip. The CT scan shows bilateral sinonasal polyposis. For the details of CT and surgery, over to Satish Jain sir, NOT. To chair the session, I request Dr. Rajbala ma'am, Dr. Anil Jain, and Dr. Yashvi.
Recording in progress.
Hello, Satish, we are with you.
Hello.
Yeah, we are seeing the DICOM images.
Yes, sir. Am I audible?
Yes,
Yes, sir.
Very.
So I think people have known about the disease. The patient has a bilateral polyposis. And what I'm going to share some of the DICOM images with you. Are you getting the screen, sir?
Yes, sir.
So what we have is the coronal images, and what you see in the left corner is 2.5 mm. So by every jump we are going by 2.5 millimeter, and 2.5 millimeter can miss lot of things. But whatever we have, what we can see, this patient has a bilateral polyposis. If you see this window setting and see this, the patient bilateral opacities and heterogeneous opacities. Can you see these heterogeneous opacities?
Yes, sir.
If you see in the soft tissue window, this is soft tissue window, these heterogeneous opacities look like fungal disease. So this should be a case of allergic fungal rhinosinusitis. Bilateral, more on the left side with heterogeneous density. So patient is allergic to some fungal antigen which has led to this sinus obstruction and eosinophilic material deposited around the fungus, giving a picture of AFRS, allergic fungal rhinosinusitis. So this is purely eosinophilic disease. And see, if you see from anterior to posterior, we can't reconstruct 2.5 mm images, but what you can see quickly, see the frontal sinuses on the left side is completely opacified with heterogeneous densities inside. As you come behind, see this is the cell here, behind. If you follow this cell anteriorly, see this cell is going right into the sinus. Can you see this?
Yes, sir.
So this is posteriorly placed cell. See anteriorly there is no cell. We don't have sagittal images. What I can see, this posteriorly placed cell. So this looks like frontobular cell. Bulla ethmoidalis extending into the frontal sinus on the left side, making the things difficult here. This is frontobular cell. See this frontobular cell, this is bulla.
Yes, sir.
If you go anteriorly, this is the level of the cribriform plate. If I go anteriorly, this is riding right into the frontal sinus anteriorly. So this is classical frontobular cell. This is posterior cell, posteriorly attached cell. I will show you once we open the frontal how it is complicating the frontal sinus drainage pathway. So drainage pathway is medial to it, and it is going right into the frontal sinus. See how much. It may require some sort of drilling of the beak to go high up around the cell. So this is one thing. On the left side is the disease, heterogeneous density and frontobular cell. Now, if you come behind, this is the ethmoids, cribriform plate, ethmoids bilaterally affected. All these are the ethmoidal cell. This is prominent. This is agarnese, bulla ethmoidalis. Now, this is the flat posterior ethmoidal roof. This is dehiscence of the posterior ethmoidal roof because of the fungal material. This is fungus. And see the sphenoid, which is inadequate septation, eccentric septation. The left one is bigger and the right one has a horizontal septa, making this above cell as a onodi cell. This is the onodi cell, and this optic nerve is in direct contact with the onodi. On the left side is a good frontal sphenoid sinus, bigger one. Complete opacification of ipsilateral sinuses, and behind all the posterior ethmoids on both sides are affected. Posterior ethmoids and ethmoids. So this is bilateral sinonasal polyposis with allergic fungal rhinosinusitis. See, CRS has variety of endotypes. Endotype means variety of different underlying pathophysiological processes going on, making every endotype a different entity. Like this one, this is AFRS, allergic fungal rhinosinusitis, where the patient is allergic to fungal antigen, which acquired in the nose from the inhalation and the eosinophilic material coming into action because of the allergy, and this kind of material is deposited. Block the sinuses, the vicious cycle starts, and then this expands the sinuses, expands. It doesn't invade. This is non-invasive fungus. And like any other antigen-antibody reaction, this is antigen-antibody reaction. The treatment of choice is steroids, steroids, and steroid. So, since you cannot give oral steroids for long, the answer to this problem is removal of all this fungal antigen along with the eosinophilic material, establish the ventilation drainage of the sinuses, and along with that, wide sinusotomies to introduce topical steroids later on. So the goal of surgery is not only to establish ventilation and drainage, at the same time, wide enterostomies, full house fast to introduce topical steroids freely into the paranasal sinuses, in the depth of the paranasal sinuses. So need of the oral steroids can be minimized. See, this is the frontobular cell. Need of the oral steroids can be minimized. I tried to reconstruct to show you the sagittal and all, but this is not clear because this is 2.5 mm section, which may not give that good a picture. So what I can see, what I wanted to show you was the sagittal cuts to show you what is frontobular cell, but it is not very clear. Let me try. This is the cell.
You blink.
This is the frontobular cell. And if I take this, not.
So we have lost the screen. Yeah, we have got it back.
Yeah, it is not reconstructing. It is, for reconstruction, we should have less than a millimeter section. Anyway, let's get on to the surgical part. So aim is to do a full house fast. Sinus surgery is a surgery of landmarks, as sinuses are in close proximity to the orbit, skull base, and a lot of other vital structures in the vicinity. So every time we should be following the landmarks so as to avoid complications. We should have a good surgical field to avoid too much of bleeding to identify the landmarks. And that's what we are going to discuss now. during the surgery.
Sir, is there anything different in the pre-op workup you would suggest if it's a simple polyposis and in AFRS, or it's the same?
Yes.
The workup.
So pre-operative workup should involve the medication to reduce the inflammation to minimize the bleeding. In AFRS, the inflammation level is very high. Inflammation, not infection. Inflammation due to eosinophilia, high IgE. So these patients should be prepared with oral corticosteroid starting couple of days before the surgery to minimize the inflammation. That is preparation.
Okay, thank you, sir.
Any other question before we start? Let's ready, case. So in couple of minutes, we'll be back to you with the endoscopic picture. कहाँ गया रमेश? कहाँ गया वो टैटुआ? रेडी है सब? हाँ सर, ये पल्स
Hello. Yes, sir. Yes, sir. Are you getting the endoscopic picture now? Yes, sir. We are getting it. So this is unprepared. We haven't prepared intraoperatively so far. And what you see the nasal space, lot of congestion. Inflammation of the mucosa. Yes, congested, inflamed mucosa. And what I'm using, my Merocell strips. Topical application to reduce the congestion. Just topical. Just simply applying the adrenaline diluted one on the mucosal surface to decongest. Never pack tightly. A tight pack can give venous congestion and can be counterproductive, can give more bleeding. See the DNS on this side, a little high deviation also, not very significant, but there were a lot of congestion, inflammation, and the goal of preparation is to reduce the inflammation. It should start, like we discussed, weeks or days before surgery. And the best for eosinophilic disease, the most potent anti-inflammatory agent is corticosteroids. So steroids should be started weeks before to reduce the mucosal inflammation and congestion. See, this kind of a mucin is classical of allergic fungal rhinosinusitis.
Yes.
So, sir, even in non-eosinophilic polyposis, the same amount of steroid is required?
Not really, not really. In non-polypoidal disease, non-eosinophilic disease, rather we give a course of good antibiotic for a week with minimal steroids.
And in diabetic patients, sir, what you would suggest?
Yeah, minimal. See, you can see now a good nasal space now after the decongestion. Earlier it was difficult to negotiate your scope even. See what topical decongestion is enabled us to go inside the nasal cavity. Can you see the difference? Simple, we don't inject, as I mentioned yesterday as well. The same kind of picture, same kind of field you can achieve with the topical along with your help from the anesthesiologist. And here I am grateful to sir, who is an amazing anesthesiologist here. You have seen yesterday all surgeries seamless, and what kind of field he has given is simply amazing. See, from anesthesia point of view, to reduce the further bleeding, overall cardiac output should be reduced, and that is achieved best in this case. In this scenario, sinonasal disease, inflammatory disease, the source of bleeding is predominantly capillary bleeding. So the best way to reduce further bleeding or to improve the field is to reduce the cardiac output, which is best achieved by reducing the heart rate. We do not pressurize for the hypotensive anesthesia in such situation where the hypotension can be a source of problem to the patient. But reducing the cardiac output is always good and reduces the bleeding, overall bleeding in these cases. This is inferior turbinate. Yeah. See the nasopharynx, torus tuberous, eustachian tube, and multiple polyps and eosinophilic material, incipitated material there amongst the polyps. So polyps, these are the polyps occupying or hanging in the nasal cavity what I have achieved, open the middle meatus now. See the middle meatus, even the turbinate has become polypoidal.
Yes, sir.
Now after this decongestion, give me again. So we have a reasonably good space on this side. Left में है ना frontal. Opposite लिखा हुआ था. लाना एक बार वो. Similar preparation we are going to do on the opposite side as well. So your preparation is a very important part. You are not wasting time, you are investing time, and it overall reduces the surgical time by means of reducing the bleeding. See this classical eosinophilic material. Oh. This side has more disease. We have seen on the CT scan. And what you see, the most important thing to notice is the high deviation. This high deviation can be a big source of problem later on if untreated. Intraoperatively, many a times you find after decongestion, feeling like going ahead with the high deviation, and you can accomplish the surgery. Even I can accomplish the surgery with this high deviation after the decongestion. See now.
Hello.
Yes.
Sir, we have lost the screen here. There was a power break.
Oh, let me know when it comes, please.
It'll take a minute, sir.
Yeah, I'll wait.
We are back with you, sir.
Okay. So what I was doing until now is topical decongestion. I mentioned earlier, this gives us the same field, yet ultra safe. The single application of this dilated adrenaline decongests the mucosa, preventing its systemic absorption. A systemic dissemination of adrenaline can be hazardous and should be avoided in such benign condition when you can achieve the same field by proper preparation. Preparation starts from preoperative part to reduce the inflammation, intraoperatively by topical preparation, by anesthesiologist's help, and you can achieve this kind of a field. Now see on this side, this high deviation is a troublesome thing, and one should not neglect, one should not ignore. You can try to do surgery along with this high deviation, but this, what will this do when you work here? This will create the opposing surfaces raw and invite synechia. That will compromise your access, particularly in the frontal region. So such high deviation must be addressed, because the goal of surgery, one of the most important goal of surgery is to give access to the topical steroids. If this high deviation is untreated, if it gives synechia in the post-op period, the entire purpose of surgery to deliver topical steroids is defeated. And that's a disaster. This high deviation can itself be a single most important cause of overall failure. One should not ignore this. One should positively treat this to prevent future problems. See, just application. So, first of all, I will treat this high deviation. And in a simple maneuver, you can treat it well with limited septal correction. That I am going to show you. You don't need to do a SMR or don't need to do too much of correction. A limited correction can treat this high deviation very easily. So what you can do,
See the same marrow cell I remove, rinse in the saline, and then dip in the same saline adrenaline solution and reuse throughout the surgery again and again. So that's the beauty of the marrow. The beauty of the marrow cell is it is so atraumatic. It can be insinuated in the narrow spaces. It expands and opens up the space. Earlier there was no space to negotiate your instrument in the nose, and now see how much it is opened up. The kind of decongestion which is achieved best in the most atraumatic manner is by means of using the marrow cell. Now first of all, I will treat this high deviation. See this gross high deviation. So what I will do, I will come from the opposite side. Come from the opposite side. Give me the, will only correct this limited high deviation, not the entire septal correction. See, my incision is far behind than a regular septal incision. I am not giving incision at the mucocutaneous junction or the cutaneous part. More than a centimeter behind that, because my aim is to correct only the high deviation, nothing else. See, only after topical decongestion, we did not inject anything. Still a thin perichondrium is left. This and elevate in the subperichondrial plane. See the avascular plane.
Yes, sir.
And that too without infiltration. See this part of the septum. See this high deviation. So now what I'm going to do, waiting for the right instrument. See now what I'm doing, I am trying to feel the bony cartilaginous junction. Just bony cartilaginous junction. See this?
Yes, sir.
I don't intend to remove the cartilage, too much of cartilage. See this? This is the high deviation. So thick. See this? This is causing deviation and limiting our access. This is the culprit. You are not supposed to remove each and every part of the septum, only this punch. You are supposed to leave a good strip superiorly.
Are you using 0-degree endoscopes?
Yes. I am leaving adequate strip above to prevent dorsal drooping. This is the true high deviation I am dealing with. That's it. Rest of the septum I can leave it. And now see. See this side.
Yes, sir.
Now
Nice
this
clear cut.
turbinate can be better medialized close to the septum. And on the same side, on the other side, this linear tear doesn't matter as the opposite side is intact. And see now, I have a better visualization. Can you?
Yes, sir.
So this is how this, see this?
Yes,
So
sir.
I have full visualization above, and this high deviation is no more something which is limiting. See this?
Yes. Yes, sir.
This linear tear will act as a drainage. See this? Now see the visualization right
We
till
can
the
see
roof.
areas
Can you
which
see very
was not
clear?
seen earlier. Yes, sir. Yes, sir. Which was
Completely
not seen
corrected.
earlier.
Now see, because of the massive polyposis, what has happened? Give me the divider. See, the middle turbinate is compressed because of the massive polyposis and the fungal disease.
Yes.
Let me just little bit debride these polyps, the luminal polyps, and show you the middle turbinate. See the middle turbinate behind?
Yes, sir. We can see.
And because of the polypoidal mass effect, the turbinate is compressed. Massive polyposis along with fungal disease. Everywhere is fungal debris. Now see the middle meatus coming in view.
Yes, sir.
All polyps along with this fungal material. Polyps and fungal material all the way. See my high deviation correction. This is such an important step. It has opened up the visualization for you. See this?
Yes, sir.
The extent of high deviation correction you can describe yourself. Your area medial to the middle turbinate. See this? We should be able to see medial to the middle turbinate and the posterior part of the septum completely. Earlier, because of the high deviation coming till here, we were not able to see the middle turbinate adequately. Now you can see medial to the middle turbinate. Can you see?
Yes, sir.
Now one of the indications for partial turbinate resection to us is polyps medial to the middle turbinate. See this massive polyposis.
Yes, sir.
Medial to the middle turbinate. This is on first sight for us is the indication for partial turbinectomy. I will show you later how important it is. Polyps medial to the middle turbinate blocks the access to the olfaction. See this? And polyps medial to the middle turbinate makes the middle turbinate floppy. Middle turbinate compressed, thin and floppy.
Yes.
And you can see, I am debriding medial to it to show you. See the state of this middle turbinate. So thinned out and floppy. Why? Because of polyps on either side. And this is the indication for partial turbinate resection, which I will complete later. Partial means first we'll utilize the value of the turbinate. This acts as a great landmark when we work superiorly. So once we utilize, we will resect the lower part and give good access for our topicals to reach to the olfactory region here.
Olfactory.
See that?
Spinach model. Yes.
Yeah. So this turbinate is never going to be stable as when you are having polyps on both sides. And at the end of the surgery, this turbinate can fall laterally like this. So this turbinate should be treated by means of a partial resection once you have polyps on either side. Yeah, see, this is just opening up the middle meatus. So now my first picture after polyp debridement. We have not practically started the sinus surgery, formal sinus surgery so far. Irrigate in between. See this? Irrigation washes away the blood. It helps in coagulation. It activates the coagulation cascade and keeps your field good. How is the field there? How is the picture there, sir?
Very nice, sir. Very clear, sir.
And we have not injected anything.
So are those fungal debris sent for a KOH and a culture?
You can for the academic purpose, but otherwise they are not going to alter the management. This is non-invasive fungus. This is allergic. The core treatment for this patient is steroid, nothing else in future. Because of the allergy.
Do you have any experience of monoclonal antibodies?
Yes, in very, very selected patients. See, in the present context, we have understood the sinusitis pathogenesis pathway, the all cascade of pathway, entire cascade of pathway at cellular level, driven by lots of cytokines, immunoglobulins. In the present context, the only thing works at every level is steroids. Steroids. Though the targets have been identified and targeted therapy, monoclonal antibodies, biologics have been developed to block the pathogenesis at the molecular level even before the manifestation develops, or further blocks the further progression if the disease is developed by targeting at the cellular level. It has been an established therapy for many of the cancers, lymphomas and all. For sinusitis, the intense research is ongoing, and a lot of monoclonal antibodies have been developed. Many of them have been approved by the FDA for the severe asthma, used for severe asthma, and some even developed have been authorized to use for severe CRS. In limited conditions, in patients where you can't operate, those are unfit for surgery. Those who are steroid resistant, those who have steroid resistant disease, those who have already developed complications and can't give steroids anymore, and those are the patients where the biologics can still reduce the inflammation. The only drawback is still they have to prove their value for long run, so they are not still time tested. Still long-term efficacy and long-term adverse effects yet to be established. So they are not available for widespread use, but surely as more studies come, more biologics develop, in future they are going to be the key treatment for CRS. Blocking at the molecular level, like treatment for lymphoma, is no surgery. Only and only monoclonal antibodies targeting at the molecular level. So this is the picture after initial debridement. Now, our sinus surgery starts, and the first step of surgery, we all know, is uncinectomy. This uncinate process is a key structure. See this? This uncinate process, see this?
Yes, sir. It's
The
also
only mobile structure in the entire lateral nasal wall, only mobile structure. No other structure is mobile otherwise. See this flat area, then this is the prominence, this prominence belongs to nasolacrimal system.
Yes.
See this?
Yes.
And behind that, behind the NLD, this mobile structure is uncinate. So this uncinate plate are practically two parts for our convenience. This upper vertical part goes up and then turns laterally to insert on the lamina papyracea. And this comes down, and the lower horizontal part runs over the inferior turbinate to a variable distance, merging either in the inferior turbinate and ending or going behind to the perpendicular plate of the palatine bone. So this entire arsenate should be removed. It opens up the access to the key areas in the middle meatus. It opens up the access to the ostium of the maxillary sinus, and a complete uncinectomy is required to prevent recirculation of the mucin coming out of the sinus going back in the maxillary sinus. So in order to accomplish a complete uncinectomy, there are many ways. The safest way, what we believe, give us right. See, this is the field. This field is only after topical, no infiltration. See, this is the uncinate, and what I am going to do, my reverse whiting, taking and turning it down and white through it, coming anteriorly, coming, engaging until I can see now the hard bone. This hard bone I am not going to bite. See this, I can feel the hard bone, this one, and this belongs to the nasolacrimal duct. If I keep biting to the hard bone, could be a disaster, can damage the nasolacrimal duct integrity, can invite fibrosis and a permanent epiphora. Now see the lower one, fractured medially, and this is the ostium of the maxillary sinus opened, and this is the maxillary sinus. In no time, see this?
Yes, sir.
Polypoidal mucosa of the maxillary sinus, you can see, this is because of the blockage. This is because of the blockage. What I am achieving is the middle meatal enterostomy. That's the part of the uncinate. That's the part of the uncinate. See, upper uncinate is still there. What I am removing is the lower part. For massive disease, obviously we need to deliver more steroids, so we need more mega enterostomies. So mega enterostomies can be achieved by enlarging the ostium. The best way is behind and then inferiorly as well. To certain extent. See, my posterior wall is visible. I can widen till the posterior wall without any difficulty.
We're still using the 0 degree, not the 70.
Yeah, 0 degree only. So this is just enlarging the middle meatus. Enlarging the middle meatal enterostomy at the expense of this bone, which is the perpendicular plate of the palatine bone, forming the posterior part of the medial wall. Enlarging, enlarging, and enlarging. Bigger the massive the disease, more enlargement is needed to push more steroids. So this is a mega middle meatal enterostomy in this situation. We'll look into the maxillary sinus later with an angle scope. Right now I am just placing one decongestant again to decongest the mucosa, inspect, and then we'll give it a wash thoroughly. See this middle meatal enterostomy?
Yes, sir.
You can see the roof of the maxilla. Now the upper part of the uncinate. This is a very, very important landmark. This upper part of the uncinate is an important anatomy. See this deformed uncinate. This uncinate is closest to the lamina papyracea.
Lamina.
See what I'm doing? Going behind and fracturing it anteriorly. See this? This way is through cut up cut. This is the safest way of delivering this. Go behind and fracture it anteriorly towards you rather than towards the skull base behind. And I can take a through biting, cut it off partially. Now see why cut it off. So now removal of this will take you to the lamina under vision. This is an amazing step that at the beginning of the surgery you reach your lateral limit of the entire corridor. That's the lamina papyracea. This is lamina papyracea.
Yes.
See, my lateral limit I have reached in no time of the entire sinonasal corridor. One कैसे हो गया? See this, the uncinate medially, can you see?
Yes, sir.
And this inverted eggshell appearance of the, see this cell, that is Agarneji. See this Agarneji?
Yes, sir.
Medial to the, or lateral to the uncinate.
Uncinate.
This is Agarneji. This uncinate, I will show you. See this. This is Agarneji. For everybody, this is Agarneji cell. I hope it is very clear.
Yes, sir. Very clear, sir.
And see, it is bounded by this uncinate only. Uncinate only. And this uncinate, see carefully, is turning laterally to inside on the lamina. Is that very clear or not?
Yes,
This
it's very
uncinate.
clear, sir.
See how it is going. And this entire cell is sitting on the mouth of frontal drainage pathway.
Yes, sir. Yes, sir.
This is something which narrows the frontal drainage pathway. This entire cell. See this inverted eggshell.
Yes, sir.
So now, back.
Very
If
nice
I-
demonstration, sir.
Pardon?
Very nice demonstration.
Thank you. So if I go behind this cell and fracture it anteriorly, there are lots of cells which are attached on the anterior wall of the frontal drainage pathway. This is one of them, and other frontal cells. And there are cells attached to the posterior wall of the frontal drainage pathway, that is frontal bular cell, which is there in this case also. We'll see another cell behind. This cell is narrowing the frontal drainage from anteriorly. See that the drainage is behind, pushed behind. And behind is the front bular cell which is going right into the frontal, riding up, further narrowing. Got my point? So that's how the frontal drainage pathway is compromised, and a slightest edema can lead to further blockage and sinusitis. So it is the anatomy of the individual sinus drainage which makes the patient prone to develop sinusitis. This anatomy is not there on the opposite side, which is not given that kind of sinusitis. Here the anatomy is making this patient prone to develop sinusitis. See this? Now at this point of time, what I will do, I'll take 70 degree to show you. Frontal drainage pathway, frontal sinus, which is considered a difficult for the surgeons. Believe me, if you follow the protocol, follow the natural landmarks, this is not difficult. What all you need to do is to do under vision. See my turbinate. The biggest thing you can do to a middle turbinate is a respect. See, I am keeping it all the way, though I am going to remove it later on, cut it partially. But right now I am keeping it keeping it to use as a landmark. I hope the picture is good.
Yes.
Yeah, excellent.
Now changing to 70 degree to show you. Now how this agar neji can be dealt with. Just behind the agar neji is the frontal drainage pathway. Yes, this is 70 degree now. And all. Yeah. This is 70 degree now. I am looking 70 degree up. I hope you are oriented.
Yes, sir, we are oriented.
This is the maxillary sinus below. This is the turbinate medially. This is the agar neji. And see how the uncinate is turned laterally to inside on the lamina. This is lamina. So this uncinate is turned laterally to inside on the lamina. Now the best way, easiest way to deal with agar neji is knowing the fact that it is attached to the anterior wall of the drainage pathway. So the best way to deal with this is, see from medially, go behind this cell and fracture again anteriorly. Fracturing anteriorly is the safest way of dealing with any structure, as you are away, your direction is away from the skull base. See what I am doing. Right, है ना दुबे सर अभी? See this. I am bringing this cell in toto to uncover my frontal drainage pathway. I hope it is clear.
Yes.
And now let us remove this cell. Removing this cell in toto to uncover the drainage pathway of the frontal sinus. नहीं चल रहा है देव राइडर तन पड़ा है कल से ही. Now see a much better picture. Now how to enter into the frontal sinus? See here. Now the next landmark to be taken into consideration. अच्छा sir वो just दिखा रहा था गणेश जी. Now see, what is this cell? This cell behind is the bulla. Can you see this cell bulla?
Yes, sir.
Behind. Anteriorly what you see is the beak. See this beak?
Yes, sir, we can see.
Laterally this is lamina papyracea. Medially your turbinate. Now the picture is very obvious, and just behind the beak is what you see is the frontal drainage pathway. Let me decongest and clear it. This is possible, this kind of visualization, only because of 70 degree. So for a good frontal sinus work, where you can do under vision, the most important thing required is a extension there. You have to be used to with 70 degree. This you can do in cadavers. You should be used to visualize and identify the landmarks using 70 degree. You should be able to do instrumentation using the 70 degree. And see now, let me remove. Where is the frontal sinus? See this. This is my beak. See, this is the thickest bone in this region. This is axilla, and underneath the axilla, this is a thick bone. This is a centimeter thick bone. 120. Centimeter thick bone, 120. This is a centimeter thick bone, thickest bone in this region, which is actually, एक बार देना mop. Actually, the frontal nasal process harboring the nasolacrimal duct below is going up to broaden to form the beak. We discussed yesterday as well. See now the beak. The thickest bone. Can you see the thickest bone very clear?
Yes, sir.
Now stay on the thick bone here. Laterally, keep your lateral limit in view. This is lamina. Keep your lateral medial limit in view. If this is your turbinate, and go behind the beak. Go behind the beak. Go behind the beak. This is your frontal drainage pathway. Now, what is obstructing? See this cell going up. Can you see this cell?
Yes, sir.
This cell, see this cell is attached behind. See this. This cell is attached behind. Let me show you. This was high riding. We could see CT scan section.
Yes, sir.
High riding and further obstructing the frontal side. Anteriorly, it was obstructed by the Agarneji. See this cell from inside. This cell. See this? And this
Yes, sir.
cell is obliterating the frontal drainage pathway. And if I overcome this, my frontal sinus is there right now, right behind that. See this? The cellular septation I am taking under vision. So CT scan is like a Google map, can tell you what cellularity exactly is there in every case. Every case is different. Every case has a different anatomy. And now see, this is your beak, and laterally where this is leading to, go along the orbit. See my direction of instrumentation, away from the turbinate. Can you see the thick beak?
Yes, sir.
Immediately behind the beak is the frontal sinus. See this?
Yes.
That is how you can pick up the frontal sinus.
So this is the RAD 60 you're using, sir?
This is now 120, sir.
120. Okay.
See how challenging it is. The challenge is offered by the various cells. So now I am just taking off the septation. Beak is, I told that we may need a little bit of the draft to widen this, because the beak is very, very thick. See this, the frontal sinus.
Yes, sir.
Beautiful, sir.
See the beak. See how, again, if you review, come to the axilla. Underneath the axilla is the thickest bone, this beak. If I follow the beak, give me 120. Follow the beak, see how thick beak it is. And I could make out from the CT scan, this, see this beak, underneath the beak, this is your frontal sinus. A picture of a sinus and cell, with experience you can make out, sinus is a thick wall. Sinus is a thick wall, see this? And cell is thin walled. You can see transparency through the cell but not through the sinus. Now we have opened the frontal sinus. The question is it adequate to deliver our irrigation? Will it be adequate to deliver our irrigation right into the frontal? No. See this? I mentioned yesterday we should be able to see the frontal sinus interior with a 0 degree, and see frontal sinus is so laterally recessed and high up. And the biggest problem is the thickness of the beak. See this beak, how thick it is. Can you see?
Yes, sir.
Yes, sir.
This is, we have seen the intersinus septal cell. Intersinus septal cell is a more anterior cell. See this?
Yes.
Yes, sir.
This narrows further the drainage pathway from medially. So this side frontal sinus was complicated by 3 group of cells. The Agarneji, the frontobular cell and the intersinus cell. Agonese from anteriorly, frontobular cell from behind, and this intersinus septal cell medially, predisposing this of frontal sinusitis. So it is the anatomical challenges which predisposes to blockage of the sinuses and sinusitis. See this? So now what I mean to say, for a routine, surgeon, you open the sinus and come out. But you know what happens? In such an eosinophilic disease, if you are not able to introduce your irrigation freely, this is going to stenose. This kind of opening is never going to allow, copious topical steroid inside the frontal. Can you see? And this should be treated right now positively. Otherwise, what happens? You come out doing after a good sinus surgery like this, and ultimately patient presenting with the frontal problems later on, and then it becomes more challenging. So you should preempt such findings and treat at the same time, rather than waiting for the more problems to happen and wait for the need of the revision surgery. So practically we have opened the frontal sinus, but this is not adequate. Looking at the disease profile, looking at the AFRS requiring steroids, this is not adequate. See this? This is not adequate to deliver copious or adequate steroids. So what I am going to do, what is the obstacle? What is the obstacle in this beak? See, this beak is the obstacle. This thick beak, more than a centimeter thick beak, right from here till here. If I remove this beak from here, imagine, if I remove this, I should be able to approach the frontal sinus head on. See this?
Yes.
This beak.
Yes.
And this is the safest region to deal with. That is what Graf has described, how to deal with frontal sinus difficult situation. See this? This beak is forming the floor of the frontal sinus as well as the anterior wall.
Yes.
And this is the region of the beak is far anterior, away from all critical structures. Away means your skull base is far behind there. This is frontal sinus, skull base is starting here.
Yes,
Skull base is starting, this is the level of the beak, 2 centimeter behind the beak, or more than a centimeter behind the beak. And in draft, you have to work far anteriorly in the opposite direction. The safest region in the sinus surgery, you deal with the draft. So don't consider the draft as a difficult procedure, because you are practically working in the safest region. Our limits of the draft, when we drill, I will show you. The limits of the draft is, as we are drilling anteriorly and anteriorly, limit of the draft is skin and skin and skin, outside skin.
Yes.
Our posterior limit of this frontal work is the cribriform, beginning of the cribriform here, that is demarcated by the first olfactory neuron. So before drilling, we will define our posterior limit here, roughly here, which demarcates the beginning of the olfactory plate. We'll make sure to see that the beginning of the olfactory plate, and then we'll stay anterior to it. Anteriorly, you can play around anywhere. At the most, the worst to worst you can do is a buttonholing. That's it, of the skin. But no critical structure. So this draft can be accomplished very well with the 0 degree now. I will show you how it can be achieved with a 0 degree. Entire draft procedure is done with a 0 degree. And the moment we remove this chunk of thick bone, this is more than 1 centimeter, probably 1.5 centimeter thick, which will require a lot of drilling. See this with the 0 degree. The moment we remove this bone, we should be able to see the frontal sinus opening head on. Head on means, Pani. See, the frontal sinus with the 0 degree is not visible.
Yes,
Can you see?
Yes, sir.
Not very clear. So this is the obstacle. You should, you
So
should
can you tell us
know.
about Caroline's window, sir?
Caroline's window is just drilling the lower part of the beak to make little bit access into the frontal sinus. So that is the terminology introduced by Richard Harvey
Yes.
in the name of his research fellow, Caroline. Her research work was impressive, and Richard Harvey named this cell or this window. This is just nothing but drilling this lower part of the beak to access into the frontal sinus. So it named it as a window. See this now. This is our area of interest to remove this. I hope you are oriented with the 0 degree now.
Yes, sir.
My frontal is above here. See my access to the frontal, which is prohibited by this beak. So now, to remove the underlying bone, first I need to remove this mucoperiosteum. And in order to remove it bloodless, what I am doing, अरे बढ़ाना यार उसको, वो बढ़ाना 9 4 ने 5 कर करो. Starting just below the level of the axilla. See, this is the axilla. Just below the level. अरे यार ये कौन सा कॉपलेटर है ये? नहीं यार. Lacrimal is much below. We are working above now. Yeah, we are going up. We are going up above the orbit now. Lacrimal is in the lower part of the orbit. We are going above the orbit. See, this is the best way to deal with the bleeding. मजा नहीं आ रहा कॉबलेटर में. See, my axilla is here and I am working far anteriorly. अब चला. Far anteriorly. See this. And coagulator gives you such an amazing bloodless field.
The posterior limit would be the olfactory epithelium.
Yeah, I will show you the beginning of the olfactory, the cribriform plate, and will define, demarcate, and make sure we don't go beyond that, behind. Right now, I am working anterior to the beak. Suction periosteum. See, never try to use your coagulator on the bony surface to control the bleeding. See this, the bony bleeding, never try the coagulator, otherwise it will ruin the blade.
Yes, sir.
Coagulator works only on the soft tissues. So for any such bony foramina bleeding, what you can do is either use the diamond or use the suction cautery. The coagulator. See, stay oriented. Believe me, the draft is a very, very simple procedure. All you need to have is a good high-speed drill.
Some people like Satish Jain make it appear simple.
If I can do, anybody can do, sir.
Satish, will there be a small vessel near the olfactory neuron?
Yes. That's a branch of anterior artery. See, I am coming from above. This mucoperiosteum elevated, and now I am going towards the beak. See behind. See, I am elevating this mucoperiosteum further. Yes. See this mucoperiosteum I am going behind?
Yes, very clear.
This is what you were talking about, sir. This is the vessel.
Yes.
This is the vessel. See the bleeding?
Yes.
This is the branch of
anterior
artery. Let me show you much better. Can you see the vessel bleeding?
Yes.
So don't confuse yourself with the neuron.
Yes.
And neuron is just behind and medial to it, if you see that.
Yes.
Can you see behind and medial?
Yes, yes, yes.
That is the neuron. So this vessel comes first and neuron further behind and medial.
Yes.
That is how one should locate.
And the cribriform plate begins beyond that.
Yes.
So that is our posterior limit.
Yes. So I cauterize that vessel. See that?
Yes, sir.
That vessel. And see my beginning of the cribriform in view now. Now staying anterior to this, I can play around like anything without any issues. Now this entire bone is exposed to drill away, and imagine when we drill this bone, we will be sitting right inside the frontal with a 0 degree. And this is the need of time in this patient to deliver good steroids. If you leave this small opening, it's not going to work. See your first olfactory neuron in view. Keep in view always. Yes, वो section करना उधर. हाँ. Neuron पे. Again, see the neuron पीछे. See the neuron behind. There.
Yes, sir.
Yes, sir.
Yeah. So this is defined. So you don't go beyond that behind. That's it. Now, this bone which you have exposed, I am working with a 0 degree. Our aim is to remove this bone. Why remove this? Again, see this. Keep oriented. See, here is my frontal. Can you see here?
Yes, sir.
Which we opened. What is the obstacle? This 1.5 centimeter thick bone. So now target is to drill the bone in the safest region. This is the simplest part of the sinus surgery, working in the safest zone. And I believe after this, anybody in the audience can do, who are not doing draft, who are endoscopic surgeon, can do very easily. Shatter your fears. Ask anything in your mind regarding draft, you can do it easily. Chalo, chalu kiya? Pani bada. See, the tool which I call as a man of the match for this is the high-speed Medtronic drill. This as a natural 15-degree angle, you can see. This is the transnasal burr. Obviously, cost is a limiting factor because this burr itself, this burr for the single use costs 50,000. And this is coarse diamond. You can see, very safe. I'm right now using at a 60,000 rotations per minute. I can increase to 75. And see under vision, this is not a cutting. This is very, very safe. Now, to orient you where I started, at just below the axilla. Can you see?
Yes, sir.
Now, first, I will go laterally to define my lateral limit. And lateral limit would be what? The lateral skin. We will see the color change. I told you now the limits are skin everywhere. Thick bone, and you will find the color change. Can you see the color change?
Yes, sir, we can see.
To see that. See this. This is the outside skin. Let me show you. This is the outside skin. See this? This
Yes.
one, let me show you. This one is the outside skin, subcutaneous tissue. And this is going to be my lateral limit. Just a minute. पानी नहीं आया. हाँ. Yeah. Can you see the lateral limit now? Much better.
Yes, sir.
The beauty is the control of the drill. Such an handy transnasal burr. You can hold it like a pencil. The shaft doesn't come in the way. And you cut this thick bone like butter. See this? Being coarse diamond, you are very safe. With high speed, it cuts very fast. In our setup, we've accomplished one side draft in less than 10 minutes. See the outside skin, can you see?
Yes, sir.
All the way skin is our limit. Everywhere around, she's cutting like a butter. Cutting the butter. See all this bone which were prohibiting us to see the frontal sinus with a 0 degree, coming between us and the frontal sinus being removed, and this drill is cutting like cutting the butter. See this? Follow this skin anteriorly. The same skin that is going to be your anterior limit. The same skin anteriorly, and up to the skin you can remove anything. See this? Deepak sir must be itching to drill this.
Sir, so much of radical surgery must be giving a lot of crusting post-operatively.
This one?
Yes, sir, because
Not really.
to
Not
make a,
really.
frontal
In this
open-
era of irrigation, in this era of steroid irrigation, which is actually an anti-inflammatory agent, the inflammation remains very low to give crusting. Believe me, hardly any crusting, and it mucosolizes very fast, provided your irrigation is judicious post-operatively. See now what I am doing. I can see my skin turning anteriorly there. See this?
Yes, sir.
Whatever bone coming, remove the bone to give the widest opening.
And physiologically speaking, sir, the opening so much, the allergens would go in so much more easily.
Pardon?
It's the allergens would go in so much easily. After all, the nose, all these things were made so that the sinuses are protected.
Yeah.
But once we open them out totally so much,
See,
sometimes allergy actually increases. It doesn't really decrease.
no, it doesn't work like that. You are giving access to the most potent anti-allergen. What is the most potent anti-allergen? Steroid.
Steroid.
Yeah, compliance is not there, but they
Yeah.
will take
So
it for
if
some
you
time and
keep
stop it.
irrigation regularly, then never bother. Your patients, doing well for 15 years, 20 years, they are judiciously irrigating and wonderfully doing well without any oral medication. Need of the oral medication is over once you give access to the topical. See, everything being done with a 0 degree. This much thick bone being removed, and so easily. Anybody can do it. Believe me, it is the simplest part or addition to the sinus surgery. See what you see the frontal sinus. Wherever you reach the subcutaneous or the soft tissue, keep using the cobblator. See this? Still a little bit of the bone is left to widen it. Now, when we come medially, before that we will ensure where is our limit, the posterior limit. See this, my first olfactory neuron is here. Can you see? I can do freely work anything anterior to it without any hassles. See my frontal sinus? Drill.
Yes, sir.
What an amazing technique. And this has opened the gateway to deal with the pathologies within the frontal sinus head on. And this has, expanded the indications for the endoscopic frontal sinus surgery. Now, this approach is not used not only for the dealing with the inflammatory pathologies, but other pathologies as well. The tumors, we deal with not only benign but even the medical malignant tumor, wherever it is applicable endoscopically. We use this technique to deal with the frontal sinus CSF leaks. What all it gives is the exposure. Once you have this kind of exposure, see, this is the posterior table of the frontal sinus. If you have this exposure, any leak coming from there, you can easily deal with that, like any other CSF leak. See the frontal sinus wide opening. Now, depending upon the sinus size, you can give the widest of the opening. It's not in your hand, it depends upon the anatomy. In large bigger sinus, you can give more bigger opening because you are widening to the limits. You cannot go beyond the skin. You cannot go posteriorly through the skull base. So, keeping the limits in view, you can give the widest possible, which I am going to show you in this particular case. See the frontal sinus with a 0 degree. Can you?
Yes, sir.
Now, this is our posterior limit. Again, keep always in view. This is our olfactory neuron here. Look now. Our olfactory neuron is here behind. See this? Staying anterior to this. If you want to go to the opposite side, do the draft, I can go from here to the opposite side very easily, staying anterior to it. Let me show first with the 70 degree to apprise you what we have done so far. 40 degree. I hope you have been oriented so far.
Yes, sir.
Simplest way, staying anterior. See this? Safest zone. The danger is here behind, that is olfactory neuron. Do whatever you can, play around anywhere anterior to it. The limit is the skin. See, if you cross your limit, you will give a buttonhole. Now see. Now see, using the debrider, I am further widening the mucosal edges. See the frontal sinus. This frontal is that much big only. Can you see?
Yes, sir.
It's not in your hand to give the opening according to what you need. It depends upon the anatomy. This is the supraorbital cell. See this one behind the frontal sinus. This is frontal sinus, and behind this is the supraorbital recess. This is all supraorbital recess. Going laterally and above the orbit. But this is always behind the frontal sinus. Giraffe. See the frontal anteriorly and supraorbital behind.
Yes.
Section. And remove this party wall to widen this. remove this septation, the party wall, to further widen the, see, the mucin, far laterally placed. See this? Reverse this. See the frontal sinus, amazing view of the frontal sinus. Now this is skull base blade, reverse blade. And see now. Now how much further you can widen? See, this is your skin. You have already reached the subcutaneous tissue. Already reached. Give me the drill. But still I can widen it more medially. Now if you, sometimes you have a disease in the opposite frontal. You don't want a limited disease. You don't want to go through the opposite frontal drainage pathway. What you can do? Just do an intersinus septotomy by the drill here and allow the opposite to drain through this. That is called, if you have no disease on this side, suppose an opposite side disease, but because of the anatomy are not able to go through the opposite side because of the previous CSF leak, whatever, orbital transgression, you don't want to go there again. Go to the opposite virgin side like this and do an intersinus septotomy and drain that opposite disease sinus through the normal sinus. That is called modified mini Lothrops. We have been doing 5 or 6 varieties of draft procedures besides the draft is described. Modified hemi-Lothrops, modified subtotal Lothrops, modified central Lothrops, mini Lothrops, variety of situations depending upon the location of the disease. It's not same for all. Funny. Now see, little bit of the widening you can do further by means of removal of the remaining bone. See this?
Yes, sir.
Under vision.
This burr comes in the same size or different sizes?
Pardon?
This burr size is universal, sir?
No, not universal. What I am using is 4.5 millimeter coarse diamond. Now see, this here below is my, see this? First olfactory neuron, just below. This is my first olfactory neuron here. See this? And I am working just above that, so as to widen maximum. See this? And now I am going to the opposite side to show you. So when you go medially, make sure that you stay anterior to the beginning of the cribriform. That is the opposite side. You can see. See this?
Yes.
So from the same side, I am going to the opposite side to show you. If I remove the disease from this side and drain the opposite side along with the septotomy to access far laterally, that is called modified subtotal Lothrop.
Sir, would this lead to any external deformity in future?
Pardon?
External dorsal defects?
Not really, not really.
Okay.
Not at all. See, under vision gone to the opposite side. You can widen to the level whatever you want to. Since we know there is no disease in the opposite side, we have seen from the scan. So I am not doing much. I can remove this complete septum and flush to the posterior wall. See this complete septum flush to the posterior wall. I can come anterior and remove the upper part of the nasal septum. This is the upper part of the nasal septum. I can drill this and do the same big opening on the opposite side if you remove the upper part of the septum. My posterior limit, see this in your mind. See this neuron?
Yes, sir.
Stay anterior to it. You can play around and do anything staying anterior to it. In this case, since there is no massive disease or any disease in the opposite side, so I am not doing further. But if there is, I can remove this intersinus septum completely and flush to the posterior wall. Remove this upper part of the nasal septum and drill till the opposite lateral wall and make a common opening, modified Lothrops. This is what we have done now. See, what we have done is we have removed the floor of the frontal sinus. Can you see the frontal sinus?
Yes, sir.
We have removed the floor. This frontal sinus now is directly draining in the nasal cavity. This is called marsupialization of the frontal sinus. If you do on both sides, that is called modified Lothrops. The same description was done by the Lothrops by the outside approach 100 years ago, which now being done purely endoscopic, which was described earlier by the open approach. Oh, the reverse. So now coming to the drainage, frontal drainage pathway below in the ethmoids. See this? Using the reverse burr now. See, I am anterior to the skull base. See this? Under vision, my cutting edges are in my view. What a safe burr it is. Because my skull base is behind, direction of my cutting burr is, the blade is anteriorly towards me, away from the skull base. Skull base, see the skull base is in front of you. And we can flush the skull base. So this is frontal sinus, supraorbital cell, and this is the anterethmoidal roof. See, in continuity. My cribiform is here medially, which I am not going to do anything. See the fungus.
Yes, sir.
And that is how, see, I am coming from anterior to posterior. This is anterethmoidal roof. See this? Bigger section. See the frontal now. Why I did? Because that narrow opening would not work, and this patient who leaves such openings have to come back again. See, if you do such things, the need for revision frontal sinus work will be over. In this era, no patient wants a revision surgery. So in first surgery, patient lose the fat very easily. So whatever you do, keep in mind, if any need for future surgery, accomplish that in the first go. See all fungus and all anterethmoidal roof with a 70 degree. Can you see? I hope the understanding of the graph is very clear. Any doubt, anybody? Please come forward. Any question or anything regarding the graph? I hope it is pretty clear.
Yes, sir. It's so clear that there is no question so far.
So coming back to 0 degree.
Audience can pass over the questions if you have any.
नीला क्यों दिखता है यार?
Everybody's totally floored.
Yes, now with the 0 degree now. See your frontal with the 0 degree. Both frontal with the 0 degree now. This is your olfactory neuron. Always keep in mind and stay anterior to it.
Will you give a steroid wash before you close up?
Yes, yes, always. ये दूसरा 0 degree था नहीं OPD में. मंगाओ ना यार.
What do you use for that, sir? Is it hydrocort?
Dexona.
Dexona.
Most potent. Out of all steroids, the most potent is dexamethasone. Now see, coming back to what we had done where we left the 0 degree earlier. We did a middle meatal enterostomy. See this?
Yes, sir.
We have done the frontal sinus work above. This is the anterior ethmoidal roof. Now the whatever work left is a posterior ethmoidectomy and sphenoidotomy, and this side is over. So we will show on one side only. This side will be finished by somebody so that we can save time for the next case. Now see, this is your middle turbinate. See the disease medial to it.
Yes, sir.
So what I will do now is the time to take it off. See this? Leaving the upper stump, a little bit of the stump. I can take this down. अच्छा नहीं? लो. Changing to a different 0 degree now. Yes, sir. Much better. So कहाँ छुपा के रखा था कल से सर? So this is to uncover the area medial to it. See now, the first structure I need to see at this stage, the most important structure before going behind, I need to see here is the sphenoid sinus ostium. Sphenoid sinus ostium is one of the most important structure you must keep in mind before you go behind. Reason being, it tells you exactly that you are anterior to the critical structure. See, I am going close to the septum.
Yes, sir.
The best way to identify the sphenoid sinus ostium is stay close to the septum, not close to the turbinate. See this, close to the septum, flush to.
Yes.
Now see, this is the upper limit of the maxillary sinus or the orbital floor. Can you see?
Yes, sir.
Just below the orbital floor here. Idea is not to go above the level of the orbital floor. See this. If I go above the level of the orbital floor, I may hit the sphenoid roof. Stay just below, flush to the septum, and you are right in the
Sphenoid.
yeah. Simplest way
The
to
superior turbinate is polypoidal here, sir.
yeah. See this fungus there. Beauty is go flush to the septum.
Yes, sir.
Always flush to the septum. Safest way of accomplishing the sphenoidotomy is staying flush to the septum and never widen it inferiorly too much, otherwise you can injure the vessel. Now staying anterior suction very mota. See now, it orients you that how deep you are in the sphenoid sinus. See this?
Yes, sir.
If I ignore this and keep going laterally, I may hit the optic nerve or carotid artery without realizing where I am exactly I have gone. So never try to go from laterally. Just follow the septum, flush to the septum, but just below the level of the orbital floor. Widening medially the safest area. See this? Now knowing the fact that the sphenoid depth is behind, you see the opening of the sphenoid sinus. No carotid artery optic nerve through cut is going to come anterior to the sphenoid sinus ostium. Never ever in any extreme abnormal situation, they cannot come anterior to the sphenoid sinus ostium. So what I am doing, I am removing this part of the turbinate, staying anterior to the sinus. Can you see?
Yes, sir.
One can easily remove without any fear, staying anterior to it. Suction karna. See this bone I am removing. Staying anteriorly. Now this soft tissue I will debride by staying anteriorly. Yes. See, debride. Now I am keeping my sphenoid in view. See my sphenoid there? Now
Yes, sir.
anything anterior to that. See this?
More fungus.
Yeah. Anything anterior to that I can remove without any fear. See, I mentioned this is a surgery of landmarks. The tigers are all around. The safety quotient is low. So you have to keep your landmarks in your view all the time. You have to develop new landmarks as you go deeper. See this? Debrider. So my biggest landmark while going behind is the sphenoid sinus ostium. Anything anterior to that I can take away. See this? Anything anterior to the ostium. This is Onodi cell, we know. Could be Onodi cell. So when you go laterally, you have to be careful. See this? All material in the... This is ethmoidal cell, post-ethmoidal. Sphenoid is below. See this? Where is the sphenoid? Sphenoid is here below. So don't go directly into this cell. This may take you to the critical structure. So always keep in mind the sphenoid sinus. Now I will remove this party wall to see inside. This party wall under vision. Now this is widening of the sphenoid. See this?
Sir, we have lost the endoscopic picture.
Come on. Audiovisual. Let me know when, then only I will remove the septa. So let me know when the picture comes. Divya, देखना यार उसको एक बार.
Yes, sir. Yes. We are back.
Got the picture?
Yes, yes.
So
yes.
see what I was doing. I was removing the septa. The party wall between the sphenoid and the post-ethmoid. See this?
Yes, sir.
This bone. I am not going laterally into the post-ethmoidal cell. Remove this party wall. See this? And further widen your sphenoid. This is the safest way of widening the sphenoid. This is fully widened the sphenoid. See above, and there is a lot of fungus out there. No? My sphenoid worsening is still left behind. See, little bit of the post-sigmoid work is left and this side is over. Curve section there. See, more. Yeah, this fungus being flushed away. See this fungus after flushing?
Yes, yes.
This is one of the best way to dislodge by means of irrigation. See this?
This patient has had a very extensive fungal collection.
And this we could make out from CT scan if you remember. I told because of heterogeneous densities, you remember?
Yes.
Section count. See how radiology is important in carrying out your treatment, in planning. This is interior of the sphenoid where the fungus is flushed away. Give me a flush again. A little bit of the, yeah, come out. Look out there. Right. And now see the wide sphenoidotomy. Now everything anterior to it I can easily take. All this cell anterior to it. Under vision. कट नहीं रहा यार, मजेदार नहीं है. खोल. Blocked. So all the cells anterior to the sphenoid you can effectively handle now. See the full house face through biting.
There is a bleeder somewhere.
Pardon?
There is a bleeder, yeah.
There are hardly any. This is our irrigation most of the time. Not very active bleeding anywhere. Minimal oozing. You have to make sure that all cells are opened up, all fungus been removed, and all areas are accessible for the topical steroids to penetrate. That is the goal of surgery. That is the stump of the middle turbinate above month. That is just the stump of the middle turbinate. Yes. See the wide middle meatal enterostomy. See this? Wide sphenoidotomy, and we have seen the wide frontal sinus. All three major dependent sinuses have been widened enough to receive the topical steroid perfuse. Uninterrupted. The moment corticosteroids start going, this is going to revert like magic. This is all
How much
sphenoid
blood loss
sinus.
has been there in this case, sir?
Pardon?
How much blood loss?
Hardly
in
any.
this patient?
Where is the blood loss? This is all irrigation material most of the time, not blood loss.
if it's oozing a lot,
Looks
do
in
you
the
give,
camera. It's not oozing a lot.
Trenexa? Do you give Trenexa intraoperatively?
Not really.
So,
Nothing.
not really.
See the septation. See the skull base getting uncovered. The final work. See my skull base from above, and this how it is flushed. How it is flushed. My olfactory neuron is here. See there? They are up. They are up. Yeah. So this is the area of interest. You have to be gentle. यार खोल के देना यार. खोल के दे. That is the probable site of leak in sinus surgery if you are not careful. Find out. See now, this is the olfactory area. See this? See this?
Yes, sir.
I didn't do anything to this olfactory mucosa to ruin this. Now this is accessible for the topical steroid to go. This is the olfactory strip medially. This one. See this? So these patients many a time they present with loss of olfaction. This is my first olfactory neuron, which I am not disturbing.
Yes.
And see the entire skull base completely flushed. No hidden areas.
Yes, sir.
This is all cribriform plate medially. This is all cribriform plate right from here till here. Here, which I have left. See this. This is the cribriform plate and the olfactory region. See this?
Yes, sir. Yes.
Which I am not disturbing. See this?
Yes, sir.
Yeah. So we can give only access to the topical steroids to reach there. Many such patients with such polyps in medial to the middle turbinate, they present with loss of olfaction. And if you don't damage the olfactory mucosa and give access to the topical steroid, majority of the time their olfaction returns back. See this?
Yes,
This is a full house fest. See this? No septation, no barrier is left for our solution to go freely to the depth of the sinuses. Nothing is left, no barrier.
Yes.
This is true full house fest. Now such patients, you have done a complete bony work, limits all around. These patients, what they all need is irrigation, irrigation, irrigation. Since they have allergy, they have eosinophilic disease. So we tell them, these patients, the surgery is not the cure. Surgery is the beginning to the cure. Way to cure. This allows the topicals to reach inside. It's a medical disease, steroid dependent disease. We give access to the topical, so you don't need oral steroids often. And that's how the role of the surgery. So actual treatment begins, core medical treatment after the surgery, but that would be topical.
Yes.
We are switching from oral to topical, the steroids after the surgery. So the goal of surgery is avoidance of the need of oral steroid by means of giving access to topical. So Convince your patient. Counsel accordingly that don't tell them we'll operate, you will be all right. That will be the biggest joke. Tell them the surgery will make sure that you don't need oral steroids. This is a pure medical disease. Steroid is the answer. If you don't get operated, keep on taking oral steroids. But since they have their own hazardous side effects, the best advisable treatment for you is to get this full house surgery done. And surgery has an important role in giving access. See, if you do a limited sinus work, minimal, small endoscopies with not this kind of a picture, the steroid will not penetrate deeply and the patient is going to come back. Failure. So all failure depends upon the kind of surgery you do. Full house face is the need.
Yes.
See, your overall success depends upon your surgical exercise, the kind of surgery you do. But don't tell that the surgery is the cure. It's the way towards the cure. This is full house face. Anything less than this is going to invite problems, as will not allow the topic. See now, perfect exposure.
Yes, sir.
Any questions? The other side we are not demonstrating for the time constraints, so meantime we can take questions or some session can carry on. And the last case would be an interesting one, probably the
Excellent demonstration, sir. Very nice. And you can hear the round of applause for you.
Thank you so much for your attention again.
Sir, there is a question from the audience.
Please.
Duration of inhalant steroids to be given post-op.
How can you limit them? Because see, this is a lifetime medical disease, allergy. So what you can do if the patient remains in constant follow-up, according to the need, you can reduce or increase the concentration of topical steroids, concentration and frequency. If the mucosa has come back to normal, no allergy going on, with all precaution and all, you can reduce the frequency and reduce the frequency and the concentration of the steroid. If in any given situation the allergy is increasing, mucosal edema is appearing, new edema appearing, you have a good access for the topical. Just increase the concentration and frequency of the topical irrigation. So entire, the treatment is switched from oral to topical. That is the beauty of full house face. No need of oral treatment in future. According to the need, you can accordingly, increase or decrease the topical therapy. The overall gain of full house face is you switch to the topical therapy. नीचे से हटा देना इसको. From oral to topical, you switch your treatment completely by means of a full house face. Now the entire steroid can reach the depth of the sinus mucosa after this excess full house face, and no need of oral therapy. Thank you very much for your attention.
Thank you, sir.
Thank you very much, sir.
इसको हटाना.
Thank you, sir, for such a mesmerizing houseful face. I would request Dr. Prabhat Gupta, sir, to please felicitate our chairpersons. Sir, please. Dr. Rajbala, ma'am. केलं.
It is my proud privilege to chair the most important session of panel discussion. I invite Dr. Milind Navlakhe, Dr. Sudhir Kadam, Dr. Sudhakar Ved, Dr. Sanjay Agrawal, with Sanjay Agrawal, and Dr. Rajiv Pachori. Dr. Rajiv Pachori, and Dr. Samir, Dr. Deepak Haldipur, Dr. Kirti Kedal.
Hello.
Dr.
Check.
Sudhakar sir.
Hello.
Dr. Kirti.
Thank you so much. I think Dr. Deepak Haldipur is outside. We can call him also.
Dr. Sanjay and Dr. Deepak.
Sanjay Agarwal sir, तो यहीं पे थे अभी.
We have Dr. Deepak Haldipur as panelist and Dr. Sanjay Agrawal sir as panelist. Please take the position on dais.
So, thank you again, and it's a pleasure to have all of you. So it's an interesting talk where we spoke, Dr. Satish Jain spoke a lot about the different
Recording
complications and challenges that can occur. So we'll be a little short and brief since it's already little lunchtime. Some are already having lunch. So we'll just try to put this and try to finish the panel before the next session starts so we don't delay the things. So we have just a few interesting cases. So we have a 45-year-old male, a very typical case which comes with a long-standing history of ear discharge with progressive hearing loss, and it shows cholesteatoma. So the canal wall down, and of course Dr. Haldipur has seen this video so many times, so I will request him to comment the last after everyone. He knows all about this. Because he's already been in this panel 1 week before. So so this was actually what was done during the surgery, and so it was a very well known, maybe experienced surgeon, and then suddenly he gets this massive sinus bleed. So it was quite a panicking situation which was there, and if you see, the bleeding was quite torrential before you could actually understand what happened. So we can start with, I mean, have you ever faced such a situation? Hopefully not, but in case someone close to you must have seen this, what would you advise? How do you think you manage this?
I've seen a few situations like that. The first thing is like how the person is holding the bleeding.
Correct.
Hold the bleed, and if it's a small bleed, like yesterday there was a small bleed,
correct,
that can be managed with Surgicel.
Correct.
But sometimes the rent is too big. So in those situations, we've used crushed muscle from the temporalis, and that actually withholds the bleeding.
So you basically use temporalis muscle depending on the amount of the tear that has occurred.
If it's a
correct.
very large one,
Very large one. Yes, yes.
like this, it's a torrential.
That's right. Yes, Dr. Pachuri, you must have seen a lot of these.
Is it my video? And it is very common. Actually, most of the time we don't record this because while doing mastectomy, we don't. I think hardly 10 of one time we get the recording this thing. It usually it happens, it can happen with anyone, means whether learning or very old senior. Nothing to be done that you did the right thing that you kept a finger over there. In the meantime, just arrange whatever is available with you. That surgery shell is best,
Correct.
take a muscle.
Correct. Correct.
And in the last end of it take hardly 3 to 5 minutes. And I think the bone wax is again good option over here.
Correct.
Keep it over there, do your other work, and then you can, the last you can pack it over there.
Correct. So,
Call for help. Sometimes when you're a junior consultant, you should never hesitate in calling other people.
that's a good
for
point.
help.
That's a good point. Yes, Dr. Vaidya, sir. I mean, I can ask you. You must have seen your juniors doing this in your college, you know. So, would you still tell them to go ahead with the surgery, or you tell them you control this and replan the surgery if the surgeon's composure is quite okay?
The best thing will be to just to pick it before you are use fingers to close it, and then you can use it a simple cotton swab or a gauze piece, because at that time in the painting nothing is available. You are panicking, so you put anything which is available, and then you can replace with the surgery cell or gel foam. In the meantime, when you are finished with the other work, you can reopen and re-examine and see if there is any bleeding. In small bleeding, they usually stop.
Yes.
They usually stop. You don't have to do anything. But for this kind of the bleeding, you may require muscle.
Muscle.
But you do not stop surgery. You continue doing with it, because this time happens many times. And if you know, if you have got a CT scan in hand, you know as prior to the surgery that there may be a bleeding.
Correct.
And every surgeon encounters such kind of bleeding
Correct.
in their practice, so they must be well aware. But you are able to control it. It's not,
Correct.
It's not that it may bleed and you may not do anything.
Right.
So it's not very difficult situation.
But it's a panicky
Creates a
situation.
panic in the OT. That is
Right.
the only thing.
Right.
Yeah.
Yeah. Deepak sir. Now I'll ask you first. Now, since I've been associated with you over a long period of time, your concept of doing a CT scan has changed. Initially, you said you were not doing it. Now you do it much more compared to what it was. So would you think doing this is also a lesson for people that doing a CT scan could have possibly avoided such a drastic thing if it's...
Yeah. See, I come from Baswangudi ENT Care Center, supposed to be one of the meccas for otology.
Yes.
Where 36 years back, we took pride in saying we don't even do a mastoid X-ray because we can manage everything. But in today's era, I feel mandatorily every case you take up for surgery, you should do a scan. I remember in Chennai, in KKR's course, Madhavaya sir once started a mastoid. He just took a first shave with a burr, and the torrential bleed he got from the sigmoid sinus, the patient bled a few, 300, 400 ml within matter of 1 or 2 minutes. Second, for beginners, when you have a CT scan like this and a sigmoid being anterior, is one of the best indications for inside out procedure and the endoral procedure which Sanjay Agarwal does. In that approach, you are less likely to damage the sigmoid sinus. This is one important point. Second, when you accidentally open the sigmoid sinus, beautifully somebody has put a finger, that is the best thing to do. If by chance you're putting a cotton ball, see that the cotton ball is a real big one, and then put the other things. Sanjay will answer the other things. Right. My advice to youngsters, one is CT is mandatory. If the CT shows a highly anterior jugular bulb and you're operating on a cholesteatoma, inside out approach would be a far better approach.
Right. So Sanjay sir, I mean, you do an inside out approach specifically for such, that's just a protocol which you usually follow because of your training.
I always do.
Yes.
One thing I would like to add in this.
Sir.
This situation happens when the surgeon is bit casual or in a hurry.
Correct.
It is the point I want to mention.
Yes.
It happens with all the great surgeons, but I have seen in my experience it happens when the surgeon is bit casual. मैं अभी एक निपटा के आता हूँ.
Right.
Like that. Yeah, he is in a hurry. So surgery is surgery. We have to take each and every case.
So you
very
can't take any
meticulously.
surgery lightly, however senior.
That is the main emphasis I would like.
Vinesh, actually
Yes.
one more thing. When we have extensive granulations, so around this sigmoid sign, and when we try to take out casually, either we should take with the proper quarter. Sometimes we
So you
try
have to be
peel it off,
careful in the dangerous
that is more
areas.
difficult. That is more
That's-
difficult, and
That's a good point. So
And I urge all young surgeons in your bedroom or in the operating room or in the changing room, have a photograph of a boxer, which we used to see in forensic books, pugilistic attitude. The boxer's initial position. Most of the complications occur when you drop your guard, when you're careless.
And the point is, if you are seeing any kind of change in the color, you use a diamond burr rather than using a cutting burr initially.
Correct.
Yeah, that is most important. And if the jugular bulb is high, the sigmoid sinus is going to be forward. So it should be seen if you see a high jugular bulb in the CT scan.
then you have to be careful about the area of the sigmoid sinus also. Right. So now we have another interesting case here. So this was a patient who was had a traumatic facial palsy. He had history of the facial palsy, not immediate, but about a week or 10 days after. Now it was a grade 5 palsy, but the CT scan surprisingly did not show any obvious deformity, bony fracture. And then we took the patient for a facial nerve exploration. So obviously, as we saw there's a bony chip there that we're removing that was embedded onto the nerve. I'm sure it's edited the video, and you can see the damage over that part of the facial nerve in this area, which was damaged because of it. Now the point here is that in this case of traumatic facial palsy, it's not about the surgery of what exactly was being done. Sometimes small bony spicules, I feel, can be missed on a CT scan, even if there is no fracture line. I have seen patients without any evident fracture line. So when would one really want to operate these patients? I mean, would you like to wait? Would you like to operate? Yeah, Pachuri sir?
Actually, sir, most of the time I do record all my cases.
Right.
So in such cases, I always go for our recording. We usually delete after 1 week or 2 weeks. And we see the recording, and suppose during the surgery we found anything right, even because you forget many things on the table.
No. The point is, this patient had a trauma. It was post surgery. The patient basically had a.
Is it RTA or after surgery?
No. The patient had a RTA.
Okay,
the trauma was not by me. It was by someone else. So the patient had a RTA, and the facial palsy came a few days after the accident, not immediately.
1 week, I think we just
1 week or so. We did a scan. The scan was not showing any evidence of any fracture line. So we waited. So
we should ask for 0.5 mm cut chassis temporal.
Right. So sometimes it was not showing. So the point that I'm trying to put across is that when you would explore, if the CT scan is not showing an evidence of a fracture line,
1 week is, I think.
You will wait for 1 week and would explore. That is what we are trying to say.
Because usually it is happening after 3-4 days. It is getting after 5 days.
Sir.
CT scan is only one aspect of your diagnosis. It may miss a few spicules, but what you should be doing is your nerve conduction study.
Yes.
And the electromyogram. That will tell you about the degree of depolarization and whether it is likely to recover or not.
Correct.
Today, if you notice, because I attended that course by that lady from Spain, who is an authority on this, surgery on post-traumatic facial palsies is almost coming down to zero.
Right.
Some overzealous surgeon in my city does decompression on 21 days for every patient and claims results. But I think CT is next important. Nerve conduction studies done periodically will be the guide for you to whether operate or not.
Right, sir. But the point here with this nerve conduction studies is that in the initial 1 week, they did not show any massive degeneration. So the medical treatment, which was obviously of steroids, was tried.
Wait.
So
then you better wait. This bony spicule causing the palsy, recovery later, debatable.
Mhm.
So either you have to be over aggressive and explore these cases, which I don't agree with.
Right.
Again, fortunately, I have Dr. Vishwas Vijaydev, my ENT facial plastic, who gives me the clear signal when I should be doing a decompression or a re-exploration.
Correct.
Yeah.
Right.
Okay, there are two things here. If it is iatrogenic trauma, which is not in there in this case, you have done a surgery or some surgeon has done a surgery, there's a palsy after 7-8 days, be very aggressive because patients and medically they do feel upset. Nothing was done. With a trauma as it is, you can
Right.
be little more relaxed.
Right. So, okay. So now you want to add something?
Regarding that point, nerve conduction test, I think the most of them these tests are done by neurophysicians actually because it at our place.
Right.
And they do use their EEG machine because, and sometimes that machine which they use is almost, because I have faced few cases where the facial palsy was clear cut, but the conduction test was normal. Means that was positive. So means it is their test at non-metro cities like we are practicing at. It is an issue with us, so that in that case we have to.
Now the machines we have are so superb with surface skin electrodes.
That is it.
Even EMG is no longer painful. No, subject has
Right.
gone to another level.
So anyway, sir, we'll come. Yeah.
Sir, I would see the grade of palsy. You said grade 5.
Right.
So with grade 5, with as he said, wait for a week, give maximal steroid therapy. If the grade comes down and it is drastically improving, I would wait. But if not improving,
You would like
go
to
ahead and
explore.
open
Yes.
it.
Okay. So this is the
Just
next.
finish, I would add one point.
Sir.
Dr. Bharti gave a thesis topic to a PG in JSS Medical College, 3 years, 162 cases of Bell's palsy, presenting with grade 5. All of them recovered over a period of 2 years.
Right.
So your minimal
but that's,
trauma causing nerve edema may show grade 5 at the end of 10 days. That may also recover beautifully.
Bell's palsy, there most of the time they
I
recover.
think, yeah, I think we're diverting from the main topic of Bell. Bell's is an entirely different discussion here. Right. So we have this interesting case. Now, of course, a 42-year-old he was being operated for a mastoid, like a routine thing. With a lot of edema around the ossicular chain, soft tissue in the middle ear. So it was tried, and if you just carefully have a look here, you can see. I hope you can see the video. Yes. So it was being, and in that process, that was the stapes which was there down there, and the stapes is totally dislocated. See that? This is the stapes that is dislocated, and it's totally out in while removing the soft tissue and the edema. So, have any of you encountered such a problem? I mean,
yes,
this was my case. I mean, I did it, and of course, we managed not to get a SN loss, but it was so edematous that we didn't realize that it was draping the stapes so much, and it could come out so easily. So, the point which I'm trying to ask is that if something like this happens, it can happen to anyone, I felt, but something like this happens, what best would you like to do? We can start from Dr. Vaidya. Yes.
Yes, I got such a case long back, about 35 years back. The patient name I still remember. She still comes to see me. The point is, if you extruded anyway the stapes, you have to put it down back,
Put it
along
back
with the
again.
soft tissue around it,
And
and
pack
you
it,
have to
yes.
treat the vertigo which you get afterwards for some 4 or 5 days.
Yes.
In most of the cases, such cases, they improve.
That's actually
Point is
indeed,
that
yes.
the removal of the granulations around the stapes is a difficult proposition. You
Yes.
must be very careful and use sharp instruments like sickle knife, which are very good. And if you are not able to do it, you can leave them.
Right.
That is the best approach. And they usually become like epithelial burrs. You can do in the second surgery. Most of the time, they disappear. Even putting a gel form of the steroid or the stapes granulation works very well. So
Right.
it's not, you don't try to mingle with the stapes too much. if there are granulation around it,
So you have
because
to be
the
careful.
extrusion.
You have to be careful while doing it.
Point is this: the patient gets vertigo for 4 or 5 days. There is a prolonged admission. You can avoid sensory neural deficits by putting it back and putting some connective tissue around it. But still, there is a chance that patient can get a sensory.
Right. Sanjay sir.
Yeah, we have to look for the foot plate first.
Yes.
What is the position, and accordingly we have to take actions.
Yes.
This can happen with anybody.
Yes. So just for the
I
audience.
don't think
yes.
any surgeon has not done this. For the postgraduates and beginners, the moment stapes is dislocated totally like this, don't do what Minesh did. Just take fool's fascia, vein graft or temporalis fascia, put it around this opening that you have created nicely, put a bit of gel foam. Don't do ossiculoplasty in the same stage at all. Don't try to reposition the totally dislocated stapes. Leave to fight another day, seal that area well, give steroids, and at the end of 6 months, assess the hearing. If it's a good airborne gap, go in the second stage and do any reconstruction.
But then, yes, agreed. But at the same time, just keeping a fascia there, along with some amount of material to seal, what are the chances of the leak and the sensory neural loss at that
Not
point
at all. Take a very big piece. What have you got to lose? Build it up from facial nerve onto the promontory. Important thing is seal it well. That's all. Put lot of gel foam.
Correct.
It heals beautifully. You
Right.
see a nice, beautiful membrane. This re-putting the stapes, you are an expert. You could get away with it. The chance of SN loss are very high the moment your stapes is opened up. Remember one thing. The moment you open the vestibule totally, time bomb is ticking.
True.
Close it as early as possible because it's not like a stepidotomy. You are operating on a infected ear.
So that's precisely what we did. The
Yeah.
moment we realized, we immediately decided. But anyways,
And
so
sir,
there are.
listen, one more thing. More than infection, if it is diffuse tympanoid sclerosis, and if you open the stape, you have taken out, then it is worse than infection.
Yes.
Then always put a vein graft and then for second.
The point is seal it and don't do any damage.
Open this, go to 24 suction and stay away because perilymph is like real gold.
Right.
Yeah.
Right. Okay. So that's a good
Point
thing.
is this, that you must be carefully avoiding it. If the extrusion of the stape should be avoided. That is the most important, because if you mingle too much, then there is going
There
to
is a
be
chance.
And even
Yes.
if you do, there will be granulations, there will be tinnitus post-operatively if you handle too much
That's true.
stapes.
Because in many cases, if chronic or the tympanic membrane incidentally had a small perforation from where it was coming. So we all presumed it to be coming through the eustachian tube, which was not. And then we did an HRCT, and the HRCT showed a defect in the area of the tegmen. We also did a MRI 3D reconstruction, which showed exactly the defect and maybe a little bit of the size of the defect. It shows that they did show there are multiple defects, all right. So when we opened the ear, okay, as we started the surgery, it was just a huge leak coming from all over the place, from the middle ear, from the area of from the mastoid. It was just plain CSF coming, and the patient incidentally didn't have meningitis for so long. It was a young lady. So in such cases, when you have CSF coming out, for idiopathic reasons, you really don't know the reason. What is the best you should do? I mean, some people say, of course, you go first neurosurgically, put in a lumbar drain, reduce the ICT. But those are things which maybe we don't come to your mind immediately. So what is the best thing what you can do? I mean, what we did was, of course, we did try to localize the leak. We couldn't localize it anywhere. Finally, we patched the leak, did a cul-de-sac closure, and so far the patient is doing fine. But any other options which you all can have, any of you all have seen? Yes, madam. Yeah.
I would evaluate for any high pressure.
Increase ICT, yes, that was done. That was done, yes, yes. And it was not there, that was evaluated before. So there was no increased ICT. We checked for the CSF rhinorrhea, we checked for the eustachian tube, we checked for everything, but we don't know the reason of this leak. And of course, there was one reason in which she just said that she had a small fall maybe 6 months ago, but that was a long time. So we don't know if it can be attributed. So now we have multiple leaks here which we are seeing. So what is the best way you think you can seal it? Just by glue, by Surgicel, or
Fascia.
fascia? Yes.
Not like endoscopic CSF, because we have, in this case, we cannot put to fat like this because it is going to happen and recur again after 2 or 3 years, not
Yes.
exactly.
Yes.
So just make a window, put a whatever cartilage from up, and like we do for the open CSF repair, not, and we cannot support it by this. Why, if you do this, this patient is going to recur after 2-3 years. 50% chances are there, right, in this way. Because whether the high CSF leak means pressure is there, but this, you have a high risk in this such case.
Right, right. So what we have done is we have done a cul-de-sac closure with a muscle flap, but yes, of course, yes, you can
The
add.
point is that how much big is the defect?
Yeah,
and it is whether it is iatrogenic or because of the disease or
No,
spontaneous.
this was iatrogenic. This was
Anything which is coming out through the CSF, if there is a brain tissue coming down, then you have to that brain herniation or brain fungus that is called. So you have to cut it and then you have to do a 2-layer or 3-layer closure. That is most important. Because I had one case in which the tegmen was gone, sigmoid sinus was gone, posterior canal wall was gone, the anterior canal wall was gone, whole brain tissue and the cholecytoma was there in the brain. Then I have to remove the cholecytoma between the brains and then I have to do a cul-de-sac. That was the only thing I could do because everything was leaking.
Right, right.
So
I think what you
importantly,
did,
you have to close it. That is most important because it's very difficult to, if it recurs, then it is again becomes a second surgery.
Correct.
In the first stage, you should cover it at least 2 or 3 layers.
Right, right, right.
in the absence of benign intracranial hypertension, I tend to believe this was due to the trauma which happened 8 or 6 months back.
Correct.
If it is multiple leak and you're not sure of identifying each and every leak and seal it, what you have done is the best. Rotate the muzzle flap, cover the cavity well, and do a blind sac closure so the patient doesn't get attacks of meningitis again in life.
Correct, correct, correct. Sanjay sir, you're in the private setup. So would you always involve a neurosurgeon? Is it always advisable to involve a neurosurgeon in these cases as a standby, considering it's the CSF and the patient might get some herniation? I mean, especially in the private setup.
Well, I work in a multi-specialty hospital and we do.
Yes, and you will always involve a neurosurgeon. Yes, yes. So that's a good advice. I mean, even you might be a good ENT surgeon, always keep a neurosurgeon. And then there are a lot of discussions if you have to put in a lumbar drain to reduce the ICT and things which can be, of course, discussed. Now we have this is an important nice case which we did recently. So a patient had progressive hearing loss, and of course it was a planned surgery for a glomus. Now, considering that a glomus which is there, I just wish to know what is what we had to do here in this case, because the tumor was much bigger in the epitympanum, in the hypotympanum, also involving the ossicular chain. We had to initially do a canaloplasty to widen it, to know the extent of the tumor. So is there any role for any other approach? Like what we did was, if you see, we did a canaloplasty, we tried to elevate the flap, but the tumor was found engulfing the whole ossicular chain. It was found going up to the epitympanum, the hypotympanum, engulfing the ossicular chain, going up to nearly up to the area of the editis. So this was the whole tumor coming out. So any other approach one would like here? I mean, would an inside out, like you see the first picture here, it was totally along the whole ossicular chain here. So is sacrificing the ossicular chain an option here, or you try to preserve it? Does it really damage the ossicular chain here? Yeah, anyone can start, yes.
Canalplasty is important. Point is this: if you are going to put a bipolar, a cautery, or something inside, it's very difficult to put if you do not have a good exposure.
Correct.
Right? Dr. Satish Jain did without canalplasty yesterday.
Right.
But for such a glomus, you need a wide exposure.
Right.
And the ossicles you can even remove, because the glomus is, if you are not able to preserve them.
So you have to remove the tumor first. That should be the main aim. Yes, yes.
As Satish showed it, you attack the feeder vessels. Usually the two small caroticotympanic arteries, they supply these jugulars.
Correct.
And then sometimes a vessel coming from the promontory.
Correct.
The tumor might have gone all in between the ossicles. The blood flow will not be there. Exposure, it depends. Small one you can do transcanal, otherwise myetoplasty, canalplasty, or you have to do a canal wall down.
Correct.
Some people also do a small posterior tympanotomy and try to take out the segment in the sinus tympani. But ultimately, whatever exposure, as far as the ossicular chain is concerned, if you can retain the stapes superstructure, you can reconstruct the hearing very well in the same sitting or next time. You can sacrifice the incus and the malleus for better exposure and better tumor removal.
Correct. Correct.
Take care to remove carefully around the stapes.
So the point is to try to preserve the ossicular chain, because there's not going to be a vascularity in that area, a feeder vessel. But in case you can't, then there are various ways you have to do it. You always have a chance.
Invariably, in and around the stapes,
correct.
I have not seen a feeder.
Correct.
I've seen a feeder along the facial nerve.
Right.
One feeder coming somewhere near there.
Right.
But usually it's the tympanic artery. Whichever it looks very
You're
good.
talking about usage of torque.
Or
any
even a
prosthesis.
cartilage, any
even cartilage.
prosthesis.
Yes.
See, when there's a superstructure, the snug fit is totally different.
Correct.
When it is only a foot plate, no matter what you do, whether you put a torp, whether you put a titanium, whether you put a cartilage, as you said, columella.
Correct.
These things, during the healing of the tympanic membrane, they move.
They move, right.
Yes.
Right.
That's the reality.
Right.
So, in
anyone,
about 1/3 of people, you do a tympanotomy and reposition the process.
right. Anyone would like to stage these procedures at one go, or you all you agree that we have to give him the best chance, whatever possible?
Indian patients don't like a second procedure. So what do you lose by doing it primarily? After all, 66 out of 100 will do well.
Correct.
Remaining 33 will accept the stage procedure once after 6 months if they have the conductive loss.
Right. Sir.
The stage procedure is not possible in India, as he said. So you have to use a top and or that a cartilage always, because that way there is a danger of extrusion. Or a cartilage directly as a ossiculoplasty material. That are the only two options available. And if the ear is like this, which is almost a disease-free ear, I think it will heal perfectly, say after 1 year. So there should be no, only question is of the cartilage getting resorption. There are questions are that cartilage gets resorbed. I have seen some of the cases in which the cartilage was put and then then you have to replace it or do something else, because the post-operatively patient has a hearing loss, say after 6 months or 1 year. So that is always a question.
Well, what is the realistic hearing of what you give to the patient? Because these patients, they come to us, I have tried my best, but sometimes even a 30 to 35, even 40 decibel hearing loss post-operatively, even with a strut, can happen. So what is your experience in terms of hearing loss? I mean, the gain after surgery? Because patients, patients come back and saying that I was hearing okay before the surgery and I'm still hearing the same.
And in spite of best assembly, 10 to 15 decibel AB gap, you will always find if the AB gap is already 40 decibel.
Yes.
So if you do in this assembly, means with nothing is there, because either you put boomerang, whether you put, there's so many, I think 20-25 types. In spite of all the things, the results, you can get 20-25 decibel maximum gain in such cases.
Right.
That is practically.
That's right. Yeah, but
the main thing is the eustachian tube function. So if the eustachian tube function is bad, whatever you use is going to fall or tilt, like sir said.
Right.
So if the eustachian tube function is good, you can anticipate a better result, and a bad eustachian tube.
Right.
So
it's a good point. So you have a good eustachian tube you should have. So for the middle ear ventilation, and that would also define your hearing. So
this is main important point in any ear case is to explain to the patient, particularly chronic suppurative otitis media, that hearing may not improve.
Right.
This is big. I have seen from Dr. Kirtane, he used to advise that the hearing may not improve, we may not be able to give you a good hearing, but we will remove the disease, because patients should have a realistic expectation.
Right.
When ear becomes dry, then they are worried about their hearing.
Correct.
Before that, they are always worried about whether the ear is dry or not. And then you are avoiding complications also if you are making ear dry.
Correct.
To your by yourself.
Right. So this is a case who was having a typical conductive hearing loss without any history of ear discharge. The patient only was planned for a stepidotomy, and then during the surgery, I'll click the video on the right now. So there was this thing which was there, and it was a aberrant stapedial artery which was there, which is rare. And of course, I'm showing my two videos, in which one I missed it, and one I realized it. So the question is, how many of you really suspect? For me, it was a surprise. So is it really very common? Because literature says it's very, very less, but is it very common? Has anyone really seen it? And should a person who is a little young or new to stapes, should he go ahead with the surgery, or always advisable to abandon it in case you're not so sure? Deepak sir, you can start.
If you're doing CT scan routinely for stapes cases, and if you have a good radiologist, the radiologist will always tell you the foramen spinosum is absent and there's a persistent stapedial artery.
Yes.
If you're a beginner, don't take it up at all. Even if you're a seasoned person, on table, if you feel it is obscuring your foot plate and you can always abandon it. At the same time, as a senior, if you're confident, go ahead and do it. Only thing is, if it's an intact stapedial artery, don't try to cauterize it.
Right.
So don't try to cauterize a stapedial artery.
That's right.
If it is not bleeding. If it is bleeding, then you have no choice.
Correct.
You have to either pack with adrenaline-soaked cotton, wait, hope it stops.
Right.
Otherwise, no.
So that's a good point, not to cauterize it, because it's connected to your middle meningeal. And will it, I mean, the point we understood about the absent foramen spinosum, but how often do we really look at the CT scan or the radiologist see a CT scan, because the incidence of this is less than 1%. So sometimes you tend to miss it in your whole practice, and radiologists don't take it so
Actually, less
seriously.
than 0.1%.
Yes.
In my, see, I did my first APs in 1992.
Yes.
34 years I have seen one case.
Yes.
So it's good academic discussion, but ultimately, on table, if you see this, then you see if there is space. Otherwise, don't abandon.
Go
it.
ahead, don't abandon it.
Involve a senior or something.
Right. So you would like to add something?
Yes, for a junior, it's always better to abandon if he is not well versed with the situation for any case.
Yes.
But if you are confident enough, you have got an experience, you can do it. There is no problem. For any kind of facial dehiscence, perilimb gusher, like say persistent SABL are things, whether to abandon or whether to continue is ultimately the decision at the moment. And with your experience, do not panic and then decide.
Right. Yes, you want to add something? Yeah, time over. Okay, so Dr. Pachuri is hinting that he has a good watch and the time is up. Anyway, so that's perfect time for us. So we have a quick discussion, because there we have some people also want to have the lunch and the OT is starting. So what are the basic take-home messages for everyone, including me, is that you have to know your anatomy, and something happens, you stop, don't panic. Protect the labyrinth and the facial nerve at any cost. If plan A is not working, change the approach, don't panic, and know your limits. Above all, the goal is not to complete a planned operation, it's have the patient safe. And most important, this is dedicated to Dr. Rajiv Pachuri. So this is an important thing, because he sometimes tries to be very helpful to everyone, and we'll see this video.
Hello, I'm so sorry. I've always loved her. He says he's so sorry, and he's always loved you. Please come up and talk to me. Please come up and talk to him. You. Oh, too late. Just telling you have to try it once. Almost let my own fears stop me from embarking on a relationship, and I would have lost the love of my life. Darling, hang on, Helen. I'll have you down in a jiffy. Hold on tight. Helen, at least just give me a chance. Go to him. It's nice that you care so much about it. Without love, we're nothing. But what about his wife? It was.
Okay, thank you so much. And so under pressure, good surgery is not about doing more, it's about knowing what to do next. Thank you so much, and it's a wonderful time. Thanks to all the panelists and all of you. Thank you so much.
So I thank all the learned panelists for the very useful discussion. And also I thank moderator Dr.
Thank you, Dr. Manish, and all the esteemed panelists. I request Dr. Ashutosh Nima sir to please felicitate our chairperson, Dr. Namdev.
There is one last surgery will be demonstrated just now. It's already induced patient. So that's a unilateral polyposis. Dubey sir had just called me. So you can get your lunch plates back to the hall. So, and after the surgery, Satish Jain sir will come. So if you all want to interact, then you can have some questions then.
So the next case is a case of 26 years old female patient. It's a revision case. Patient presented with unilateral nasal discharge, nasal blockade, and headache. On CT scan, it's showing pansinusitis on one side. So over to OT, Dr. Satish Jain sir. To chair the session, I request Dr. Rakesh Maran and Dr. Anupriya Hajela to please come and chair the session. Hello. Hello, OT.
Hello. Hello. हेलो दोनों साइड लगाते हाई डेविएशन है हाई डेविएशन है हाई डेविएशन
We don't have the OT picture here yet.
Hello.
Hello, sir.
Yes, can you hear me?
Yes, sir.
Yes. So actually, this is a case of for the revision sinus surgery. Unilateral disease. The other side is absolutely normal. And the previous surgery was done how long back?
2025.
Done 1 year back, and it looks like a persistent disease. We saw the last case, full house fest. The aim of surgery was very, very clear to give full access to the topical steroids. If this doesn't happen or you don't achieve, things are not going to work and will need either oral corticosteroids or revision surgery. So, isko rehne do yaar. So now the case is ready. See, it's a unilateral disease, nothing much on the CT scan to show. We have only printouts. So I'm just getting on directly to the endoscopic picture to show you what can be done more in a revision situation to get better results. What all lacuna, which is, made us do a revision surgery in this situation. दोनों तरफ लगा दिया 7:30 तो इसके बाद सामान पैक कर रहा है पैक करके छोड़ने के लिए निकलेगा नहीं. So, are you getting the endoscopic picture now?
Yes, sir. Yes, sir.
So, right-sided disease, Guru. Hello. Hello. See now the biggest problem. Can you see?
Yes, sir.
What is there?
It's a high septal deviation.
High deviation. This is the single most cause of failure if not realized. See, all sinuses are not exposed to the topical steroids adequately. See this? And it looks like previously the adequate work was not done above because of the high deviation. This is the single most important factor many a times. And this happens after decongestion when surgeon realize that he can negotiate his instruments and adequate space without doing anything to the septum and ultimately results in this problem. This is a significant high deviation. Left side is otherwise normal. See this? Paradoxically bent turbinate. Paradoxically bent. See this?
Yes, sir.
Just, the simple answer to this, because this patient doesn't have so far sinus disease on this side, but it can predispose to. See this? So this can block the osteometal complex. This is a concha bullosa. What I can do simply to take away this paradox, partial turbinectomy. See, there is a cell inside. Can you see?
Yes, sir. Posterior concha.
Yes. And now this will open up the middle meatus. Only this will be good enough to treat on this side. And otherwise, this anatomical abnormality can predispose to sinusitis. See this, the through biting does it. See, the cell has been removed, middle meatus opened. Okay. Through biting. This has completely opened up the middle meatus on this side. Divide. This turbinate is something which could predispose to sinusitis. So that's the final solution to this paradoxical turbinate. Wash. See this? The frontal recess pathway is open. See above? The maxillary sinus pathway is open. See here? This is the hiatus semilunaris. And this is no longer going to give any problem on this side. See, nothing is required to be done. This is how one can treat the paradoxical turbinate, and the need to treat that. Otherwise, if you ignore this, can give rise to the future problem. Now this high deviation, use high deviation. See this? Significant. I don't know the status of what previous surgeon has done for the septoplasty or anything. Let's see. Same what we did in the last case, if you remember. Hello?
Yes, sir. Yes, sir.
Same way of
So what is the
handling.
age of this patient?
Can somebody tell, please? 18 years.
Okay, sir.
Something definitely was done by the previous surgeon to the septum. And I can feel some fibrosis. I don't know what was done. Anyway, hear this? In between, we don't see the cartilage or the bone.
Septal bone is missing.
Yeah. Because something was done during the previous surgery, which we do not know. Bone is missing in between. Fibrosis. Yes. Now, see as compared to the previous case, the high septal deviation after the septoplasty. See this?
Yes, sir.
This is contributing to the high deviation. Neither. This is a very, very important part of the surgery. If you overlook this correction, you cannot get the desired results. Okay. Let's see. See this synechia.
Yes, sir.
Look right. Pulling the septum laterally. That's the synechia. See, remnant of the uncinate, not removed. See this?
Yes, sir.
And see the polyps. Through it. So there are regions, surgical regions of failure. not the disease related, surgeon related. Now the space is opened up. इधर करो इसे. Let's reassess. Now see the picture what it was earlier and now, and the need of the revision surgery. See this material. Can you see the axis now?
Yes, sir.
Completely changed. It is the axis which matters. Surgeon, without correcting adequately, tried the instrumentation through the narrow space. Because of the opposing row surfaces, synechia developed. No steroids going inside now, and ultimately a failure. Right. See this? Now what an axis. High deviation correction means giving access. It is so critical, so important it is, you can't imagine. And because of this persistent high deviation, even the uncinate was not removed completely, upper uncinate. What can you expect in such a case? The frontal sinus work. Imagine. See now the axis getting. And now I have full access. See the full control over this side. Can you see?
Yes, sir.
Complete control over the access on this side. Now see the space we have created. See the remnant of the uncinate again.
So this is a
Even the
40 rad.
uncinectomy was not complete.
Yes, sir. So this is a 40 rad debridable.
Yeah. Red 40. We discuss a good uncinectomy is required. The first step of sinus surgery needs a good uncinectomy, reverse writing. And uncinate was not removed. See now the axis. High deviation removal doesn't mean that we are going to remove the entire septum. Only for the axis. You should remove to the level that it gives unparalleled access to the steroid to penetrate. See, the remnant of the uncinate was there. Now see the proper middle meatal enterostomy. Much better.
Yes, sir.
Now let us see the lamina papyracea. Osteitis. In revision, so see the osteitic bone. That's a common finding. Osteitis again require in such eosinophilic disease more and more steroid irrigation, more high dose topical steroids. Osteitis means the inflammation is gone beyond mucosa in the underlying bone as well. That is the osteitic bone. See, even the lamina has become osteitic. See this?
Yes.
Osteitic bone means it is a depot of inflammation. I may have to remove the lamina, keeping the periorbita intact in case it is osteitic. Osteitic bone is a depot of inflammatory cytokines. See lamina, which is generally a thin bone. See how much thick bone, bad bone, disease bone, and I had to remove. See this bone?
Yes.
This is lamina, and I had to remove, keeping the periorbita intact.
All the osteitic bone needs to come off.
Yes. Otherwise difficult to treat because this is huge depot of cytokine, I would say, inflammatory cytokines. And once you remove, the healing will be very fast. See this now, the bad bone we have removed?
Yes, sir.
Still keeping everything intact. So you may have to remove the lamina, doesn't matter, as long as periorbita is intact. If it is osteitic. See now the lamina is good. See now how good this bone is. That is the ethmoidal skull base. Ethmoidal skull base.
Yes, sir.
See the ethmoidal skull base, all bad mucosa, polypoidal disease mucosa.
Yes, sir.
So my job with the 0 degree till here is done and very clear. See the artery? Can you see?
Yes, sir.
But the covering was osteitic.
Anterior.
Reverse. See the bare artery?
Yes, sir.
The bony covering was osteitic. Doesn't matter, remove it. We don't want a disease bone. Now this is a reverse blade. See this vessel?
Yes, sir.
All bad bone removed. See this? Now I will wash karna. So the all posterior sinuses. See this? Maxillary, sphenoid, postethmoid been opened up, and this is the anterethmoidal roof now. See this lamina here?
Yes, sir.
Everything clear?
Yes, sir.
And the turbinate and all osteitic bone in the exposure. Everything fine now. Give me 70 degree. Ye do pack. Now is the time to look up. See this good access. It is the removal of the bad tissue, bone, whatever. Remove. Give good access to the topical. And see my septum. This is not never going to bother now,
Yes, sir.
as far as the access is concerned. Now coming with the 70, the last part, that is frontal. Group extension. इसको हटा दो. हटा दो.
Sir,
हटा दो.
hello.
No, करो. Yes, please.
So what is the concentration of you using Budicort, or what are you using for douching for these patients?
Yeah, Budicort. Respules.
Respules in 1 liter of saline?
Saline or nowadays more and more in Ringer lactate.
Okay. Sir.
Ringer is more physiological, contains potassium and lactates also. So,
Sir, you're using 2 respules of Budicort in 1 liter of RL?
yeah, it depends. To begin with, then again, I mentioned depending upon the finding, mucosal recovery, you can increase or decrease the concentration.
Okay, sir.
No,
And
120.
sir,
120.
do you treat CRS with polyposis eosinophilic type
Yeah.
different from AFRS? Or is it the
AFRS
same?
is more, demanding for the steroids. There are certain endotype. Now see, I'll come to that. See the axilla level? Can you see?
Yes, sir. Yes, sir.
See this thick bone. I'm staying much anteriorly. Thick bone. Thick bone. Thick bone. And where I am now? See your beak here anteriorly. See this beak?
Yes, sir.
Just underneath the beak cannot be anything else than frontal. See the frontal sinus and see the beak.
Yes, sir.
Irrigation there. See this fungal material inside. Let me flush it off. Wash mark. See flushing. Yeah. See this fungus?
Yes, sir.
Can you see the frontal?
Very nicely, sir.
Which is opened up after the irrigation. After flushing. And see again the same anatomy. This is the beak. See, this is frontal, this is supraorbital recess, shallow, and behind that is the anterethmoidal artery. Always anterethmoidal is caudal to supraorbital recess, reverse. पतला देना, बिल्कुल पतला, 1/3 कर दे इसे, और जिराफ दे. So that's see the typical location of the frontal sinus, other correction. Typical location underneath the beak. The most reliable landmark you must rely is the beak. It never changes, you know. Decongestion inside. Adrenaline packed to open up. See this? wash. Hmm. Hmm. Reverse. See the better picture of this frontal sinus?
Yes, sir.
See the ethmoidal artery, supraorbital recess.
So when do you exactly decide to convert it into a Lothrop to be?
Depending upon the pathology and need for irrigation. All that matters. I can do a limited, see this. This is a good access. There is no massive disease. See this?
Yes, sir.
It can allow the steroid. Nothing is prohibiting now. It can allow the steroid to go inside. Only thing is the beak is quite thick. So let me tell you, no, if this is over projecting with the drill, if this is over projecting, it can be punched out with this. See this. This is articulated punch. See this?
Yes, sir.
It can remove the over projecting beak to allow the access. See this? Little better.
Much better.
What an amazing tool it is. This is articulated punch from Karl Stores. It can punch the over projecting beak. See this? No, drill there. Wo the brighter. Wo the phone put. See now it is open better. Now let me further widen it. And that will be good enough. We'll see with the 0 degree the access. On slightest of doubt, don't think twice and I'll drill the beak. Not to give a chance for second time. See now. See? Much better?
Yes, sir.
With it. Further widening only with the this thing. See, it has drastically changed the axis only with the articulated punch without drilling anything. Let me show you the final picture. Now see the frontal sinus.
Yes, sir.
दे पैक दे वो छोटा वाला जिराफ वही देना. Now let me decongest and see आधा कर इसका भी. See this big frontal sinus. Can you see?
Yes, sir.
Now this won't need any draft. So your articulated punch is a great tool. It can remove the over projecting beak to give more access. See now?
Yes.
Good enough. Now give me 0 degree. Still want, you can drill a little bit overhanging beak in no time. See now with the 0 degree. This is with the 0 degree now.
Yes, sir.
See with 0 degree, I can see my entire frontal sinus. Can you see?
Yes, sir.
If you can see with a 0 degree, your patient will be able to irrigate efficiently as well. That's the great criteria of Pandal Bhai. So this side to me, the full house face is done. See the frontal above? Sphenoid behind, maxillary, synechia and high deviation removed, the frontal beak punched out. See this?
Yes, sir.
And what a great action. See with the 0 degree, entire frontal sinus is visible. So nothing more is required to be done in this. Good full house face and access to the topical. That's it. That's all about it.
So does the maxillary sinus flow needs to be flushed with the nasal cavity floor in these cases?
Maxillary sinus?
Floor. Flush
Yeah.
it off with the nasal cavity floor. by
Not in
removing
this
the-
case, yes. In certain massive pathologies, we do need, see this, the mucosa is good, reversible mucosa. We do when there are lots of fibrosis and compartment form in the maxillary sinus.
Okay.
Or sometime in the cystic fibrosis and other situations where the mucociliary activity is compromised. Now see the picture now. And see the best part is the lamina and the osteotic bone after removal. See this?
Yes, sir.
Directly periorbita is there. Osteotic bone removed, 0 degree, frontal sinus visualization, entire skull base, anterothoidal artery, sphenoid sinus, maxillary sinus, high deviation removed, and good access is there after removal of the synechia. So this case was an ideal indication for the surgical exercise.
Anupriya and Yashvir, sir is going to sit in the room, and anybody that talk with the master, you can ask question from there only. He will be sitting in front of the camera. Then whatever question in your mind, you can ask. Meet the master program. We will finish here. Then we will call off a day.
Yes, sir.
Okay.
So yes,
Right.
sir, yes. Meanwhile, we'll felicitate our chairperson. I request Dr.
Okay.
Yamini ma'am.
Sir, आइए आप बैठिए तो आप आओ तो.
I request Dr. Yamini ma'am to felicitate our chairpersons, Dr. Rakesh Maran and Dr. Anupriya Hajela.
बेटा कैमरा लगा दे फटाफट और ये कैमरा ऑन कर दे बहुत शानदार केस था आइडियल इंडिकेशन दूसरा क्या है कि नहीं आप इसकी हाई डेविएशन एस्थेटिक है हाई डेविएशन एस्थेटिक है नहीं आपने इसको कैसे फंक्शन में लगा एक दूसरे का
So we'll take up a few questions with Dr. Satish Jain sir.
Can you see the Dr. Satish Jain on mic?
Not yet, sir.
Acha, okay,
yeah, now
okay.
we can see. So
Right,
this
now you can
need
see?
not be related to this case as such. You can ask anything.
Any
from
question
last 2
regarding-
days. Any
yes, sir.
question we can take up.
So if there is no question, Yashvir.
Hello. Sir, myself, Dr. Reena Arora from Indore. I just want to ask,
about the post-op after the full fest like this.
Volume.
What is the post-op protocol you follow in irrigation?
Post-op, depending upon the eosinophilia and the underlying, pathophysiology. Like in the spectrum of CRS, at one end, the endotype which has the highest inflammation is AERD, aspirin exaggerated respiratory disease. It is at one end with the highest spectrum of inflammation, highest eosinophilia, highest leukotrinemia, and in that situation, if I know the patient is AERD, aspirin sensitivity, that will require highest volume and concentration of corticosteroids.
Yes, sir.
Because leukotrienes are formed in abundance, which are giving, the entire problem of eosinophilia and all that.
Yes.
If I know the case is AERD, primarily in a primary situation, whether required or not, I will do bilateral draft. I will do partial middle turbinate resection. I will do mega enterostomies everywhere to push more and more steroids. In a primary case.
In the primary case.
Because that induces highest level of inflammation, and the sinuses are going to get blocked if the steroids are not adequately reaching.
For how long do you prefer to give the steroids in such cases? For how long do you give the steroids in such cases?
Depending upon the underlying pathology. AERD can be reverted after surgery with the aspirin desensitization.
Yeah.
If it is reverted, aspirin desensitization is successful, the steroid can be reduced or withdrawn later on.
Okay.
Depending upon, but patient has to be on life on aspirin.
Yeah.
So it depends upon the pathology. Similarly, allergic fungal rhinosinusitis is a lifelong problem. That allergic phenomena can be reversed in a small percentage of the cases with immunotherapy if it is picked up on skin prick testing and immunotherapy is successful.
Yes.
Then you can, withdraw your steroid.
Withdraw the steroids.
So it depends upon the underlying pathophysiology.
Yeah. Thank you, sir. Thank you, sir. So for aspirin sensitivity, I've seen if you discover it early, they regress. Actually, the polyps regress. Once the aspirin is stopped, they switch over to clopid. And patients do fairly well. So doing too drastic a surgery for aspirin sensitivity, maybe they come to you late, but I have seen a good history taking as to why the polyps would have occurred and go into the drug history. Aspirin, if you stop and if it's in the initial stages, it regresses.
See, it can be picked up clinically if you are suspicious. Any patient with polyposis on history is having bronchial asthma should be tested for aspirin sensitivity by default. Up to 10% out of them have aspirin sensitivity, and if ignored, if the underlying cause is not treated, however number of times you operate, it is going to come back because the inflammation is too high. Prostaglandins have stopped forming, leukotriene switches on, leukotrienes are formed in abundance, which are pro-inflammatory agents. So, in such cases, if the underlying pathophysiology is not targeted, even if you operate 100 times, it is going to come back. That's why assessment is very important in every case. So, any case with polyposis and bronchial asthma, history of bronchial asthma, must be assessed for aspirin sensitivity.
Hello, sir.
Yes, madam.
I want to ask, suppose we have operated FES for allergic polyposis. So for how long, when we do a post-operative endoscopy, should it be labeled as a reparative mucosal polyposis, or it's a recurrence, or is it a biofilm if we see that's not healing properly and it's taking more than 6 weeks for the cavity to heal?
Biofilms can form in the post-operative period. That is a basically fertile ground for the bacteria when you have raw areas. So, and the best prevention of biofilms is again the steroid irrigation because it reduces the inflammation. That prevents biofilm formation by mechanical disruption as well as preventing the quorum sensing mechanism to establish to form the biofilms. So steroid irrigation is the key in the post-operative period to prevent biofilm formation. If a good sinus work is done, like you have seen, complete flushing with the limits and start irrigation, forget about the biofilms. Biofilms form if you leave the osteotic bone. It is almost certain to form the biofilms. And it is so drug resistant because the biofilms, bacteria, are encased in a polyglycan matrix. It is resistant to antibiotics even with 1,000 times concentration. So remove all osteotic bone, give good access to the topical steroids, and steroids are the best agent to prevent biofilm formation.
If we are suspecting biofilms, then how should we treat that patient?
So biofilms in the nasal cavity are formed mainly on two virulent species of bacteria. Most commonly the Staph aureus, and second less common is the Pseudomonas. But it is almost always in sinus surgery related situation, almost always it is Staph aureus. So number one method of biofilm treatment is if any inadequate surgery is done, you have to complete it. Like this, flushing to the limits, what we have done. Any osteotic bone, anything where the steroid not reaching, you have to ensure by a revision surgery, number one. Number two, start clarithromycin in low doses, macrolides. Macrolides are wonder drug to prevent quorum sensing mechanism of biofilms to grow. Quorum sensing is what? See, biofilms are what? Aggregates of bacteria. And those aggregates are surrounded by a polyglycan matrix. Now that matrix is something which acts as a barrier for antibiotics to penetrate. And those aggregates of bacteria secreting matrix happens when there is certain number of bacteria come together. So there has to be a quorum that has to be fulfilled for number of bacteria to come together, and that mechanism is inhibited by macrolides. Number one, start macrolides immediately, complete surgery, full steroid irrigation, and in case on repeated cultures, because they get shreds of biofilm shreds virulent bacteria in between, if Staph aureus is detected, then you can start mupirocin irrigation, topical mupirocin irrigation. That is wonder drug to deal with. That topical works like a magic to kill the biofilms. Topical has the highest concentration which you can't give in oral form or injectable form. So topical mupirocin is the killer. Fourth is applying Manuka honey. Manuka honey contains a lethal bactericidal methyl glycol. We use very often in our practice post-operatively to apply Manuka honey on raw areas to prevent biofilm formation, or if biofilm form, to treat them. It is lethal irrespective of the bacterial species. Without any culture or anything, you can apply biofilms, Manuka honey, and treat biofilms.
How much of mupirocin in the, what's the dose of mupirocin in the saline irrigation?
Ready? Change kar. So mupirocin, first of all, is not freely available. How we acquire is from the pharmaceutical which supply APIs. Mupirocin available in the ointment form is oil based. It cannot be applied. So we acquire from the API distributors which provide raw mupirocin powder. And you know the cost of 1 kg of mupirocin is almost 6 lakhs now. But 1 kg is good enough for years together. You need a very, very small solution. We take a pinch of mupirocin, mix in 20 ml of saline and irrigate. That's it.
It is very, very costly affair. Availability is issue. You can buy from the wholesale API distributors a powder of mupirocin, which is water soluble. Otherwise, the ointment is oil based. You cannot apply. It cannot work.
Circuit flight. No, circuit flight. Thank you very much, sir. It was a wonderful session. We really thoroughly enjoyed, and looking forward for your
Thank
more
you. Thank you
surgical
very much from Div Advanced ENT Clinic. Thanks to Satish, thanks to all of you. And we call it a day, and we will meet very soon again with Satish and sir. Thank you
So,
very much
big
to all
thanks
of you.
to the organizing team, the Divya ENT Center, Dubey sir, Divya, and everybody, Sanjay Agarwal sir, Deepak sir, and all the guest faculty, and big highest level of respect to the audience, the delegates for this interactive session. Thank you so much for your patience and everything. Thank you.
Thank you, sir. Thank you very much.